I like my job because when you go home, you know you made a difference.
Because it's just happy. It's nice knowing it's a very rewarding job. Very rewarding when you've helped. It could be like the tiniest thing that you've helped someone with, but it's like massive to them.
Just generally making that difference because, like I say, some people don't see anybody, or they've got a son that lives 40 miles away that comes on a Wednesday, you know, and that's all they see in general. And it's just nice that you made a bit of a difference to them, you know, conversation, chat.
They are brilliant. Richard, the carer there, and Leah, the carer there, they are absolutely brilliant. I can't fault them.
It can be a very stressful job, but on the other hand, you get more rewards out of it than you do stressfulness. And it's nice going to service users and smile at you. You made the day. If they walk in and they smile at you, you know you've done something right.
I actually did something completely different before, but because I looked after my grandma a lot, so it like enforced me to go in and help other people. So I thought if I could do it for my grandma, I'd do it for everyone else. And best job I've had so far, to be honest.
Come in and I might be feeling a bit low, and Richard will say, "Good morning, Doris," and I'll say, "Good morning, Richard, good morning, Leah," and I might be feeling a bit low, and then all of a sudden, them just saying them words, "Good morning," and "How are you today?" and they cheer me up. Really, really lovely.
It's like a lot of people, I think, "Oh God, Karen, I couldn't do that," but community is so much different. Like, some people will just go and see it to have a chat with them because they're lonely and they just want to see someone through the day. It's not all like just all physical work, sometimes it's social and interacting with them. It is quite flexible. I mean, I don't have to dedicate, if I wanted to dedicate my life to it, you can, but you don't always have to as well.
Sometimes I feel like I could put my arms around them and cuddle them because they're that good. And anybody that says they ain't, come and see me, I tell you.
Councillor Francis Purdue-Horn is substituting for him. We also have apologies from Councillor David Martin, also on other council business. There's no substitute on this occasion. And finally, apologies from Councillor Robert Gordon on other council business. And Councillor Bethanetti is substituting on this occasion. Thank you.
Thank you. Thank you very much. Declarations of interest. Oh, sorry.
Chair. Sorry, Chair. Also, I've got something on at 1:30, so I'll have to depart. I've got personal business.
That's
That's
fine.
today.
I'm hoping that we will be finished by 1:30. But yes, I
Just in
understand.
case, Chair.
I think lunch will have to be served, if not.
Thank you.
Yes, Michelle.
Yeah, I have a personal interest. My case with NUH is part of the thematic independent review, although I've not gone through the listening process yet. I have kind of signed up for it, so I just wanted to declare my own personal
That's fine.
interest.
Any others? Callum.
My employer is one of the stakeholders consulting the bachelor item.
Right, thank you. I myself have a daughter who works at Queen's Medical. Councillor Eddie. Oh, somebody had you on. Yes, Councillor McGrath.
And also, my daughter's training to be a maternity nurse as well. So,
If we could just pause for a moment while I capture all that, thank you.
Thank you.
Have we got all? Pause for a minute while we get it all down. All right. Okay, so we can move on to the. Before we do, I would just like to mention two things that have happened since we last met. I have had a virtual meeting with the new chairman of NUH, Nick Carver. I have to say it was an extremely useful meeting, albeit virtual. I think he would prefer in the future that we have face-to-face meetings, but it was a virtual meeting. It was extremely useful, and we've both been able to put points forward as to how we move along. So that was one meeting, and we are coming on to tomorrow's NUH, and of course, you know, everybody was invited to the briefing yesterday, the whole council. We did have several members who did attend, found it useful, and we will be continuing that today. So that was just two little messages. So now we'll move on to agenda item 4, which is Nottingham University Hospital Maternity Improvement Plan. We seem to be extremely blessed this morning. We have Rupert Eggington, who's the acting chief executive from NUH, Tiffany Jones, who's the Director of Communications, Sharon Wallace, who's the Director of Maternity and Clinical Representative, and Dr. Keith Girling, the Medical Director. All right, I've got that right, haven't I? Yeah. Wasn't written down, you see, so I just had to remember. Okay, so members will be aware of the rating that was given to NUH as inadequate, but following the CQC inspection. We're now going to return and hear what the people have to say from NUH, and this will help us give us an idea of how they are improving, and it will help us to look at the full improvement plan for the first time. They have recently, and I'm sure they'll allude to it, they have recently had an inspection from the CQC, and it's my understanding that you're still waiting for the report back. So that's for another day. So over to you, who's ever going to start? Thank you.
Okay, shall I say a few words of introduction?
Please do.
And then we'll hand over to others to pick up some of the detail or open for questions. So, first of all, thank you for the invitation. It's good to be here, and thank you for all the family members who are training or working at NUH. They're very welcome, and we all know how difficult it is to get fully staffed up in the NHS at the moment. So. We've submitted some information into the meeting per the request, and we're happy to go through that in whichever way you want, either by going through the presentation here or opening out to questions. So we'll follow whichever methods the committee prefers on that. As you know, we're on a journey to improve the maternity services, exactly as Councillor Saddington said, and that's programme is overseen by our chief nurse, Michelle Rhodes, who unfortunately is on leave today, so can't be with us, and through Sharon Wallace, our director of midwifery, who's here and will be able to talk through the improvement programme. I'll just say a few words up front about the CQC visit, if that's okay. The CQC came and did an unannounced inspection in the first week of March. It was 2 days on each of the two campuses at the City and Queen's. We had feedback at the end of each day, and subsequently get a letter of to summarise that feedback in the following week. And I think the summary of that visit, that the feedback actually forms part of our public board papers, and so it's in the for anyone who wants to look at that for our meeting on the 31st of March on Thursday. But there are a number of positive observations and comments on the day from the inspectors around improvements, including fetal monitoring, that mothers' individual needs were being met. We had very positive feedback about the mothers received, and that they described to the inspectors comments around policies and guidelines being up to date and new roles, etc., etc. There's lots. There are a number of other improvements to describe. Having said that, there were some comments around areas that still needed to be improved, and we've had a letter requiring us to make sure that there are improvements by the 16th of March, particularly around two areas. One around the triage service in maternity, and further assurances to be provided on that. And the second was around the observations of women who were within the unit. Now we've supplied further information to CQC since then, and indeed there are a number of actions in train to deal with those points, particularly around establishing a dedicated and separate triage service, which was part of the improvement programme, and also dealing with some of the automated alerts that happen for midwives on the in the maternity service to support that observation comment. So those things have been put in place, and we'll need to demonstrate that to CQC before the 16th of May. So I think in summary, I'd say plenty of improvements recognised by CQC, some concerns around triage and an observation. We're on track to deliver those pieces in line with the timescales that are there. We expect the report from CQC. They describe us getting the draft report about 6 weeks post the visit, and then following that, they finalise and publish on their website, and we take it through our public board at the next opportunity.
Thank you for that. Can I just check something, please? You said that you had to have improvements by the 16th of March, and then you referred to the 16th of May. So can I just clarify?
Apologies, 16th of May.
16th of May. I was thinking to myself, you haven't got very long.
Thank you.
Sharon and I will take you through the presentation that's on the screen, if that's okay. And Sharon will start off with the first part around the maternity improvement plan, and then I'll pick up on the safe practice section.
Thank you, and thank you for inviting me today. So the first part of the presentation is around our improvement plan. So it is a vast plan that we have, and we've incorporated previous reports from CQC and Ockenden and Kirkuk recommendations into that. And these are examples of how we've improved, and the headings are as per our improvement plan on the actions. So I can highlight a few of those things, certainly around our safe practice. So we identified that there were issues with our jaundiced babies. So these are babies that are going into the community and having a robust pathway and a means of identifying those babies that required further assessment back into the unit. So I'm really pleased to say that we've invested in they're called bilirubinometers. It's really hard to say, but basically they're given to the community midwifery teams. They can just apply it to the baby's head. It'll give a reading, and then that indicates if the baby needs further assessment or referral back into the unit. So that is a real improvement in terms of keeping the mums and babies at home together, not having unnecessary interventions such as blood tests, because the bilirubinometers will give you that read, and identifying those babies that do need further assessment. Our digital piece has moved on immensely, so there's now two prongs to our digital piece. So we've improved our connectivity within the community midwifery practice, in that it is now linked to NUH completely. We've invested in hardware and equipment so that midwives have that access, and that has made a really significant impact and improvement on practice and that connectivity between the unit and community. But I'm really pleased to say that we've also had investment in terms of a new end-to-end digital system. When I say end-to-end, it means that when a woman books in the community, that record will follow through, and it's in real time. So a midwife in the hospital can see what's happening with that woman. I had a similar system when I was at my previous trust. So if you're a community midwife, you're expecting Mrs. Bloggs to come, and you think, well, where is she? She hasn't turned up. You can actually see, oh, she's on delivery suite, she's having a baby. So it's a way of monitoring and having that seamless communication through the whole pregnancy pathway. And it also will link into neonates, and that's going to be implemented in November this year, which is really exciting. Staffing is our biggest challenge. I can't say anything otherwise. It absolutely is. We're working within a context of ongoing COVID issues, but also a national shortage of midwives. But we have done lots of work around our recruitment retention. I think the key for us is how we retain our staff. So having those flexible working contracts, such as term time contracts, job shares, those kind of things, and how we support our staff and their well-being at work. We've got a new HR recruitment retention person who is supporting us in driving that recruitment piece for us. We're part of a broader group of trusts who are looking at international recruitment for midwives, and that's in process. And we should be having 17 international midwives by the end of July. And also we're automatically offering our student midwives posts that will be qualified in September, because we signed them off and deemed them competent practitioners. So having that automatic offer, I think, will certainly help with our recruitment. But we have a rolling advert out for our band 5 and 6 midwives. And in terms of consultants, we've got new 4 posts out that are at shortlist at the minute as well. As Rupert mentioned, the CQC noted that our fetal monitoring had massively improved, and we see that through our incidents as well, and our training. We have a vast training programme for CTG monitoring, including external baby lifeline courses, masterclasses. We have a K2 module, which is about 11.5 hours of real time and different scenarios to work through, plus our local and the regional CTG packages. But we're also looking at our non-registered workforce, so we're pulling in line with the national benchmarking against maternity support workers in terms of their job descriptions, how they're recorded in ESR, and how their job progression can work from a band 2 to a band 4, and then hopefully into a foundation degree and into a midwifery career, if that's the path that they want to take. Lots of work around culture and leadership, and that takes the longest time as well. And our governance processes, I've come now into a team where I've been in post since the end of June. I've now got a full governance team, and we're working on making sure that we've got those robust processes and frameworks for staff going forward. Most crucially, I think, is how we listen to our families, and we know that we haven't always got that right. I do a monthly Facebook video from questions from women, from families that come into us, into the comm department, and I answer those questions. Top of the hit list is visiting and COVID and how we support partners, but we get questions around our training on equality and diversity and all sorts of different things, which is really good to have that connection between our families as well. I know that we've given you some information, our friends and family, and we've worked really hard in terms of increasing that response rate. So I can tell you that in March, we're up to about 124 responses, which is a big increase from where we were. So it's good to see that we've got 100% positive responses, but if you're only getting a handful of women, it's not really representative. So we are really pushing that friends and family, and we're also investing in a local maternity survey, a picker survey, who also run the CQC survey. And that's been shared with the MVP, and Small Steps Big Change as well, for the families to input into those questions as well. And that will be launched hopefully in May, because we've just finished our national survey in February.
Thanks, Sharon. And so the question that everybody's asking is around, are services safe? And this slide just tries to depict sort of 4 areas of safety that we've been focusing on. So Sharon will pick up the workforce piece in just a moment, because that's absolutely crucial to safety. But training has been a really key component of what we've been doing. And we've referenced the CTG training several times already. That's been a really important part of the programme, and CQC have identified that we've made really big progress with that. And if we look at our incident themes, whereas CTG analysis and interpretation was a key part of our themes, both internally and with the Healthcare Safety Investigation branch, when we started this programme, that's now right down the list of our themes. So it's other things have taken the top slots. So CTG training has been something that's been really embedded. But in addition to that, that's one aspect of training, of illustrating many aspects of training that we've invested in. We haven't seen a reduction in harm incidents, and there's a number of reasons for that. We encourage our teams to continue to report incidents as they occur, and actually high reporting organisations are safe organisations, so we wouldn't want to see our harm incidents reduce, but we do want to be increasingly confident that we're seeing less serious incidents and an increased proportion of low and no harm incidents. And within that, we have to be absolutely confident that the grading of that harm is done appropriately by members of staff. So we've done a lot of work around levels of harm and understanding levels of harm, and then making sure that our incidents are graded properly, and that we're seeing that impact. And we'll come back to serious incidents later in the presentation. And then, of course, the other part of our programme, in order to produce safe care, is to make sure our pathways for women and for babies are safe. And there's an example on the next slide of a case study, particularly around postpartum hemorrhage management, where one of our patient safety fellows working in maternity has led this work over a 12-month period. And what this slide shows, particularly at the bottom right-hand corner, is the number of units of blood products transfused as a result of postpartum hemorrhage per month. And that's really quite a dramatic reduction through the work that Naomi's been leading to ensure that women are prepared properly for delivery, such that they have a better level of hemoglobin, a blood level before they deliver, and then that is maintained throughout delivery, such that they need less blood transfused, which is clearly a risk factor. It's an excellent piece of work. It's been presented nationally and has been recognised nationally for as a good piece of work. Second, on the next slide, we absolutely needed to improve our data collection to ensure ourselves that women and babies are protected from harm, and we now have a dashboard that's been shared with you that has many domains in it that are looking at all aspects of maternal care and then plotting those outputs as SPC charts, so statistical process charts, to allow us to determine whether the things that we're doing are having an impact on women and babies or not, or whether we've got areas that need further attention. So that dashboard's been shared with you, and we're happy to talk through aspects of that. I'll hand back to Sharon on the workforce.
Thank you. So the next slide, I've kind of alluded to them anyway around our workforce. So we know we've got gaps in the workforce. We were fortunate to have the investment from NHS England based on the Ockenden review. So we bid for 1.7 million, we got 2.4 and 2.2 million for midwives, but it's specifically for band 5 and 6 midwives. But as I've said, there is a shortage of midwives, which is the challenge. That was based on our Birth Rate Plus review, which is the national workforce tool, which was done in 2020. I know that we've had a reduction in our births, just naturally. We've got around 500 less births than we had in June 2020, and that reflects the national picture in that the births will steady off and sort of plateau, certainly by 2025. So I asked for Birth Rate Plus to do a rerun. So the gap, while we still have vacancies that are significant, the gap isn't as acute as it was. What Birth Rate Plus hasn't done for me is put in the extra, the 4.5% I want in terms of the training needs for staff, because midwives, I think it's around 8 days if we do all the core competencies in a year, which is a significant time out of work. And also we also have around 20 whole-time equivalent midwives on maternity leave, so I want to have that investment in as well. So I'm going through a line by line in terms of our finances to get the absolute bottom line on our staffing and to have that workforce paper presented. I'm sure it will come here as well in the future. But the graph that I can show you is just where you see the peaks. That refers to the July peak is for the international recruitment of midwives, which I said is 17, and then the other peak is for our students who are we will be employing. We've set the forecast leavers around 4, but we have seen a reduction in our leavers. We are doing exit interviews. Last year we had 47 leavers to 45 starters, so it was a net loss. But the main reason for our leavers was retirement. So it was around, I think, 19, I want to say, that retired. And some of them have also returned, so we do offer a return for staff. The other reasons were promotion in other trusts and relocation. So we do exit interviews so that we can identify anything that we can do to help staff and retain those staff. What we are seeing is that staff, in terms of their flexibility, and because we're offering to maintain our safety, which you can see on the next slide, is how we manage our workforce. Because if I've not got enough midwives to support the workforce, what do we do? Well, actually, we offer enhanced rates, and what we're seeing is midwives that are choosing to not have contracts and go and work for the agencies instead on an HSP because it's more money. It's an agency fee. But the staff are working absolutely tireless. We, as I said, we were still in that COVID pandemic. We've got around 12% sickness at the minute, and it's how we maintain that safety. So the staff do pick up additional shifts. They work flexibly. The non-clinical midwives work as well to support the service so that we can ensure that we have a safe service. We also have a tool called Birth Rate Plus, which is part of it's an acuity tool which we input into every 4 hours. It gives us real-time information in terms of the needs of the women, in terms of one-to-one care and their acuity, so the amount of complexity they have versus the number of midwives that are on the floor, certainly on delivery suite, and also a prospective tool, so we can manage our staffing. If we can see that actually we've got positive acuity potentially on a ward, we can move a midwife to delivery suite to support those areas, and the staff work flexibly to maintain our safety. I've talked a little bit about digital transformation. The other thing that we've worked on is our maternity advice line. So this is a 24-hour service which is staffed by at least 2 midwives, and it's one number to ring into from the point where they book with maternity services. It's really positive. We did a soft launch in August and then fully launched it in October. And we've had really positive feedback from both staff and from women as well. And we monitor our times for delays in calls and responses. And we also have a fail-safe in that if a woman's in labour and she can't get through for whatever reason, there is a message that says if you can't get through, you need to ring this number. So there is a direct line into labour suite. So we're not missing those women who need that urgent care. But it has gone down really well, and it's the first part of our triage processes to identify those women that are have a clinical risk and need.
Thanks, Sharon. And then moving on to serious incidents, which I know has been a concern for the committee. And the table at the top here illustrates some of what I was describing earlier. So the thematic analysis of our serious incidents from 2020 showed that fetal monitoring was at the top of our incident profile. If you look at the 2021 analysis, then you can see that that's reduced to something like 7th or 8th place compared to other issues. So we have been trying to ensure that our improvement programme is live and real to the changes in the incident profile. So as things have appeared and as incidents through the year, and Sharon's already referenced jaundice babies, then we have made sure there's quality improvement work around those areas to deal with those issues. The rest of this slide describes the criteria for referral to the Healthcare Safety Investigation Branch. And if we move on to the following slide, you can see the numbers of serious incidents that we've reported each month and the number that are reported to HSIB. On the following slide, those numbers are then broken down for you by theme so that you can see the numbers of those incidents by theme, and you can see that there's a large spike around stillbirths, a large spike around neonatal admissions and readmissions of the baby, and in the postnatal period. And so those are areas that we are focusing our improvement programs around. Clearly, as I said, our dashboard covers a whole number of metrics, and you can see on the next slide the very sad data around maternal deaths, which we have had a number of in the last year, some of which have been COVID related and some of which have not been COVID related but have been related to other very serious conditions that women have had. All maternal deaths are reported through to HSIB and to the maternity data set Embrace, which we've also sent you the data of around neonatal deaths and stillbirth rates, which we're also happy to describe to you. And stillbirths are set out in real time on the next graph. I would just urge a caution around the stillbirth numbers. The Embrace data that we submitted to the committee is the last full report that we have from Embrace. It's the 2019 report. We would expect the 2020 report later this year, so it comes out in around September. Whilst on one level it seems straightforward to be able to define a stillbirth, the data cleansing issue around stillbirths to ensure that you're comparing different organisations appropriately takes a very long time, and that's why the Embrace report is delayed. So the Embrace report is the most robust comparator tool that we have for our stillbirth rates. And the 2019 data, we were plus or minus 5% of the median, so we were very average for the country. But that should be noted in the context of a social deprivation scores, which are also reported in that report. And we do have in our catchment a much greater proportion of social deprivation than the national the national position. So we've maintained a median position despite our social deprivation index. And in the previous year's Embrace reports, which are all available in the public domain, we have been at median or better than median in each of those years. The committee asked particularly around claim data. Now this is complex, and Rupert may want to say more about this, but we don't. The committee asked us specifically about claims. We don't pay claims directly. We pay an insurance premium to the Clinical Negligence Scheme for Trusts, and the CNST, or through the NHS resolution, pay that. It's effectively an insurance premium that we pay. That insurance premium is determined by the claims that we've had, just as it is for your car insurance premium. If you have more claims, you pay more. And the data that we can access easily from NHS resolution is our premium data that's comparative, not our payment of claims, because we don't pay that money. And then finally, the final slide from the maternity dashboard is just around readmissions within 42 days of delivery. And again, that the postnatal pathway has been a particular area of focus for us, and you can hopefully just see that that graph is certainly not going up, and hopefully we'll get some statistical improvement with the work that we continue to do. So that was the presentation we had, Councillor Saddington. Probably happy to open it up for questions now rather than take it through all the rest of the information that we've sent through. Do you want to come in?
I think Keith gave the description of the Clinical Negligence Scheme for Trusts, and so yeah, I'm happy to expand on that if people want me to.
On the claim data, we did actually ask for the total number of money paid out and the total number of people involved and the cases pending. Now, when you say it's not easily accessible, the data, I'm sorry, I just don't buy that. If an insurance company is paying out potentially tens of millions of pounds, they will have a log of what they've paid out, who to, when it was. So I just wondered, why is this data not here?
Yes, so we as a trust do not hold that data. It comes from NHS resolution. We have been in touch with NHS resolution to try and get that data for NUH, but we don't have that data at this moment.
So can I come back? Yeah. We asked for this months ago though, and you say it's not easily available. If anybody, if a taxman wanted to do an audit of that company, they would have to provide that data. You don't hand out tens of millions and not have a log of who you're giving that to. So it's got to be somewhere.
Yeah, we are chasing it and we continue to chase it. We don't have that.
Just on from there, what Councillor Cubble is saying, how come the papers are quoting figures? Where are they getting their figures from?
So I think
so they must have approached NHS resolution direct and got some numbers, I guess, is the answer. I can't speak for them. I think we have had some total numbers quoted, and I think I'm right in saying it's approximately £140 million over 10 years, which again, if you look at the premium of around £14.5 million plus the improvement total, it's consistent with the the premium we're paying. So I think that's probably the headline on it.
just add, I did ask NHS Resolution for some comparative data, but they don't share that, they don't have that, but that is something they're working on, because I think trusts are now saying actually it'd be really good to see, but it's very difficult, because you could have one really high value case or several smaller value cases, and because of maternity care, that could be up to 25 years plus in terms of when the incident happened. So if you've got a significant claim now, it doesn't mean the incident's happened in the last couple of years. It could be 10, 15, 20 years ago that those claims are brought. So it's really difficult to inform services, and that's the crucial part for us, is that we have and in part of the incidents is that NHS Resolution will give us a breakdown of the last, we had from 2017 to 2020, of the key themes of our incidents that were coming to NHS Resolution, and the early notification scheme, and HSIP are part of that as well. And that's built into our maternity improvement, so that's cross-referenced into our maternity improvement plan, so that we are actually addressing those instances where, if they're saying that there's an issue with escalation, for example, it is into our maternity improvement plan, because that's the key, is how can we get better and recognising those themes and making those actions.
Just coming back on that a minute, I find that amazing that you don't want that breakdown yourself. How do you know you're improving from the deaths you've had if you don't actually know the number of, and you can read it in the paper? I just find that amazing how you can improve if you haven't got that detail.
So I think the claim date, the claim amount is based on a whole number of factors, and as Sharon said, is often many years in arrears. I met a family last week that had a payout from not from a maternity case, but from a surgical case from 11 years ago. Now that could have been 9 years ago, could have been 15 years ago, but it's in terms of how long these cases take, and it's impossible for us therefore to keep in any sense of real time the incidents linked to the claims. And the key for us is that we understand the incident and what happened in that incident, and that we're making improvement in that in much more real time than looking at claim data that's very historic. So we absolutely understand the themes within our serious incidents, but linking that to claim data is extremely difficult.
But when you read these figures in the paper, which says, I wouldn't want to quote them because I'm not quite sure what they are, but it's so many million that's been paid out for so many brain damaged babies, for so many stillborn babies. Does it not, you don't come back and answer the paper ever and say that's wrong. So are we to read that what's in the paper is correct?
Sure.
And this, I have emails from patients, and I know other members of the committee do. So does it not concern you that the papers may be quoting, I don't know, I've seen 91 million quoted and 46 brain damaged children, something along that line. Does it not concern you that those figures are being quoted and you're not ever coming back and saying, no, you're wrong, or yes, you're right, or it may be more, it may be less? Surely that is the utmost importance.
I mean, I think it's hard to challenge because it's hard to know exactly what the figures are. I think that the fact is that settlements around childbirth can be very, very substantial in nature, and you can see in the little table that's in the presentation, the scale of the premium that we have to pay each year because of the the nature of, or the possibility of things going wrong is very, very substantial. It's about £14.5 million for the maternity service on its own, and that's more or less exactly the same as the other equivalent hospitals in our grouping. So that is in the nature of it, and it's also why nationally there's a very, very strong focus on what are the issues that lead to this, how can they be improved, because it's an enormous amount of taxpayers' money that should surely be much better be paid towards the service rather than dealing with the after effects, and that's where we need to focus our efforts.
Okay. You wanted to come back, Councillor Cubley?
Thank you. Yeah, to me it's quite simple. There should be a log somewhere, say 1st of March 2021, £1 million paid out, and a brief title. It's not a case of when did the case start, when did it finalise, what it's about. You've got to have an audit trail of that money paid out. The insurance company will. So I don't see how it's so difficult. I really can't.
So we don't have that information. It's not held by us in terms of the amount per case. We do get feedback from the NHS resolution around the cases and what the nature of the case is to feed into the improvement programme. So we have the list of claimants, but we don't have that aligned to the settlement for the very reason that Dr. Girling mentioned, is that the value of the settlement isn't known until the case concludes, and that can be many, many years after the event. So the feedback we're getting, or the information we're getting direct into the trust, is around the incident, so that we can feed that into changes in practice, as opposed to the financial component, which is settled by the negligence scheme itself.
Sorry, I can just, so when I've been to national events and NHS resolution are there, they quote that £40 billion has been spent on claims for maternity services in 10 years nationally. £4.2 billion. So because of that, and obviously the impacts on safer care, we have the maternity incentive scheme, so the CNST, which is the 10 criteria that every trust that has a maternity services has to report against, and those standards are around safe staffing and attain, and a lot of the things that we've talked about today. And that then, if you meet the 10 criteria, then you get a percentage back of your CNST insurance claim. But actually, it's about safer care. That's the important part, is how we measure ourselves against the criterion that NHS Resolution, which is our insurance company, but also provide that early notification scheme as well. So when we've had an adverse outcome for a baby, that families have that very quick, rapid recourse to financial support without going through years of legal claims. And so that's something that's been implemented nationally, and that's triggered from our HSIB reports. So it all feeds in, and for me as Director of Midwifery, it's about how we learn those lessons and know that our care, and benchmark it against other trusts and have the metrics to provide that assurance on safety. Yes, we want to save the money in terms, and we don't want to have those poor outcomes, but it's less about the money for me. It's around actually having those safe services and what we do today to make sure we've got those really safe maternity services. And I think some of those claims are historic. There might be 10 years ago, when we've moved on from there in terms of our evidence and research, and our practices change as well. So I don't know if that gives you a bit more context. So I know you were talking about the claims, but actually it's about the themes that come out of our incidents, and that we can then build those into safe practice and have that assurance through our own divisions and to the trust, and then with our external regulators.
Before I bring Councillor Welsh in, that still doesn't answer my question. I don't know whether it answers the committee's. We can read in the press, and I think it was on television one night this week, of the amount paid out and why it's been paid out, either on stillborn births or brain damage. We always hesitate to understand what we read in the paper, perhaps, but that seems to be the only way that we have any knowledge of what's going on. I find that incredible. I find it incredible that you as an organisation don't sit down and say, well, okay, we've had so many brain damage. How can you ever improve if you don't know what your figures are? That's what I can't understand.
We improve because of the investigations and the action from investigations. That's the trigger for the care, not the cost of payment. It's around how we make our services safer in terms of the outcomes from all of our investigations and review that are done externally.
Okay, well, I'll bring Councillor Welsh in, but I would ask members whether they have any concerns that we can't seem to get those figures, that we read them from the paper and we assume the paper is correct. But I'll bring Councillor Welsh in because she's probably asking something totally different.
Yeah, I've got a few questions and then a few points. I make no apology for the fact that this may be a little bit longer than needs be. That's because some of the things that have been raised now, I'd just like to pick up on. So first of all, Mr. Eggington, or Doctor, yeah, you made some comments about the findings inspection, and I do believe you mentioned with regards to triage, etc. What you didn't mention was at the City Hospital, it was said that there'd been an increase in stillbirths, but no apparent rationale been established at present. And there were some midwives who may have been acting outside of their competency in respect of reviewing scans. And it's said, and the specific thing with regards to triage, which I think it would have been very useful for this Health Scrutiny Committee to know, was women attending triage were not consistently reviewed within 15 minutes. Now, I've got friends that work within health, and I actually know how important that women are triaged every 15 minutes, because that actually reduces serious incidents massively. So that's a huge worry. So to suggest that things have massively improved, for me, those three things alone sets alarm bells ringing. If I'm really honest with you, I read that and that really worried me, because 10 months ago we sat here in this committee meeting and you brought to us, I do believe it was one side of A4, to tell us what was going on in maternity services, and it's taken us 10 months to get this level of information that we've asked for 10 months ago. Now we're talking about, Councillor Kibble has asked on numerous occasions about the 140 million. I was a senior parliamentary researcher, and I can tell you something, I could have got that data as a senior parliamentary researcher. I don't buy the fact that you can't access the information that we're asking for. I don't buy it. I'm really, really sorry. I'm not saying that you aren't telling the truth. I'm saying that somehow, somewhere, given the situation that your maternity trust is in, people would go out of their way to make sure you had that information in order for you to be able to improve. The other point that I'd like to make as well is you talk about understanding the themes and what has happened. There was a recent report in the media. The CCG had done some social media advertising at last with regards to their independent thematic review, which again this committee had asked for because it wasn't being advertised and I was contacted consistently. And the amount of people that have come forward through that has quadrupled. So that's very, very successful. If that's quadrupled, and even half, I believe it will be more from the amount of people that contact me on a regular basis that I sign. If that has quadrupled, I would suspect that perhaps you don't fully understand what the themes are with regards to what is happening at NUH, because it has taken a review that people have had to fight for, that parents have had to stand up to in a court of law and talk about their most traumatic experience to even get to the point where we're having a review. And that again concerns me. And it's all leading on from the fact is that people ask for information and it doesn't come forward. And we have to ask and ask and ask and ask and ask. And that still worries me. And today, when you've presented certain information, it has worried me about the bits that you've left out, because some of the bits that have been left out today in your presentation are vitally important for not just this committee to understand, but for the public as well. So I'm going to go through some of them if I may. They are within the white documents towards the back. So if we look at, for example, page 19 when you're talking about the midwifery establishment. So one of my questions is, and I'm assuming I'll go through it and then you can probably answer at the end, although there'll be quite a few. You've partly answered this, but where are we going to get these midwives from? Now, I'm aware, because I've been doing something with the Royal College of Midwives with regards to this on a campaign, there is a national shortage of midwives. And I think it's something like 600,000 are due to retire this year alone. So it's a massive national issue. But here at NUH, we can't have an issue where we can't get midwives because of the situation that we're in and the fact that women's babies and safety is all compromised. And it's still compromised. I know of cases that have happened very recently. In fact, someone has spoken to me only yesterday where a very serious incident happened in November that didn't know how to access the review, by the way, as well, which I found absolutely, I can't believe it, that she's spoken to a number of people at NUH with regards to what happened and nobody told her or referred her to that review. So there's an issue there as well with regards to it. So that's my first question. Page 21, where you talk about the maternity advice line, you've actually answered part of my question with regards to that, with regards to the fact there are 2 qualified midwives answering the phone. Absolutely fabulous. I had a qualified midwife that answered the phone to me when I said I was having contractions. She didn't look at my file and told me it was Braxton Hicks. So the most important thing for me with regards to a phone line is that actually those women are being listened to. And it isn't a case that that phone line is act as a triage thing and that women aren't coming in because all the triage beds are full and they already can't do the 15 minutes. Now, I know that's happened in the last 4 weeks as well. So that's my question with regards to that. My other question with regards to this, which you may or may not happen, is that to increase the capacity on the ward so that they go to this direct line? Because obviously previously, like when I phoned up, it went to the actual maternity department and it rang for quite a while, I have to say, before anybody answered because they were obviously really busy and short-staffed. So is that to stop that? And what is the capacity on that line with regards to 2 midwives? Is that actually enough would be my other question. So if we then go to page 24 and we look at serious incidents by category, I have a question with regards to, I do believe it's second part, I can't quite see, I think it's nearly the highest. Neonatal unit admission not anticipated prior to birth. Can you clarify what exactly that means? And you also clarify the next biggest one, and I excuse my pronunciation, I'm not medically trained, interim fetal death, stillbirth, where it's really hard. Is that just saying the serious incident is a stillbirth and that's it? That's my other question. Page 27, forgive me. 27, we've talked about this already with regards to, I think this needs to be a lot clearer because this isn't just a document for this Health Scrutiny Committee, it's a document for the public. And this claims data, as I understand it, doesn't directly relate to the maternity department, it relates to the hospital as a whole, is that right? Or is it just to the maternity? Okay. And then I would like to ask a question with regards to page 34, with regards to emergency C-sections. It never really goes down, does it? It never really goes down. And the reason I'm asking about emergency C-sections, and sometimes it's difficult, isn't it, when you've been through your own personal situation that you think in a certain way. I should have never have had an emergency C-section. It was completely avoidable, completely avoidable. So my question is, what work are you doing with regards to why are these people having emergency C-sections? Now, we all know that childbirth is risky. We do. Everybody knows, and some things are just unavoidable and you have to have an emergency C-section. But how many of those have been avoidable would have been avoidable. How many of those are people where women have not been listened to? Because my worry is that's still an issue with you at NUH, that women are not being listened to, and this is causing a problem. Page 39. Special cause concern with regards to neonatal deaths. Number 44 graph, could you clarify exactly what that means? Doesn't special cause concern have to be reported somewhere? Is that to the government? And I just wondered what was happening with regards to that, because if you look from September 21, it's going up. Stillbirth rate has gone up to January 22. So this isn't old data. We can't say we've made loads of improvements because it's old data. This is true to life data, but the stillbirth data's gone up. And we'll go on again, shall we? Page 43. Page 43. Increases in both of those. I mean, number 55. Neonatal hypoxic, I can't say it, except grade 3 in inborn term death. November, it goes up. Can we have some explanation with regards to that graph? Because it goes up, and then it plateaus, and then it goes up. What is the situation for that? Because if I was just looking at this data and statistics wise, I tell you what I would be thinking about this department, that it doesn't function. That one day you can go in and you might get an all right service, and then the other day it might not be. And that has always been my worry. I have a friend that had a baby only last week within your hospital and have to say the most amazing experience ever. So I don't believe that every woman that walks through and baby that walks through your door is a terrible experience. I don't believe that for 1 minute. My worry is that it's a bit potluck, that it depends what day it is and what is happening in that maternity department as to whether a mother or baby, what happens to that mother or baby. That's what my concern is, and that's what my concern remains. And that doesn't just come from this statistical evidence, it comes from what women are telling me about their experiences. I do want to talk a little bit about, I mean, I could go on. I'll name some of these pages perhaps for you to look at and perhaps the rest of the committee to look at. Page 48, moderate harm and above. Okay, that needs looking at with regards to the graph and what that's saying. Page 60, 61 and 63, staff sickness and staff turnover within maternity. And I think you need to really look at, and this is what the public and everyone needs to know, how many of your staff are recommending it as a place to work? Have you seen that graph? So what is happening within that maternity department for people to say, I don't want to work at NUH? I don't want to work in the maternity department at NUH. Because that is a very, very serious issue. So either there's a cultural issue going on, or safety is being compromised and midwives don't feel safe being a midwife within NUH. It's one of those two things, or both of those things. And I think we need some open transparency with regards to that. Because that graph, if I was either of you two, I would be alarmed by it. Just like I'd be alarmed by those 278 more people coming forward for that independent thematic review. I would be very, very worried about what those outcomes are going to reveal. Extremely worried. And I'll go on. Page 69, socio-economic deprivation. I don't believe, and in fact, I can show you the research, that NUH has particularly high deprivation to other hospitals surrounding it than across the country. For a start, Kingsmill, up the road, has higher socio-economic deprivation around its hospital than NUH does. Significantly high socio-economic deprivation. And yet you look at their figures and it's very, very different to NUH. Very, very different to NUH. Page 71. Gestational age where the national rate is 1. If you're looking at the graph on there, it's 17.5% for NUH. So while the national rate is 1, it's 17.5% for NUH. Why is that? How can it be so different at that hospital? These are the things, really, that you should have pointed out to this committee. It shouldn't take me reading at home last night, going through all this, to be fair, I've calmed down a little bit this morning, getting more and more wound up that we should have had this data months and months and months and months ago. Councillor Adams spoke about the data. Unfortunately, Councillor Lee isn't here. I don't know if he's on. He spoke about his own personal experience. We asked for this data 10 months ago. And we've not had it. And this is what we're having now. And when we see it, I can tell you some of this data is frightening. It is really, really frightening. S16, where it says women and their babies treated by the right number of appropriately skilled and competent staff, is red. This is in here. The women, let's just say that again, the women and their babies at NUH treated by the right number of appropriately skilled and competent staff is red at NUH. And we are supposed to sit here, and I will say the improvements such as the maternity helpline, the fact that you're telling me that we need to be grateful, me of all people, that we need to be grateful that you're now monitoring fetal heart appropriately, when I was lying there and you couldn't find a machine that worked in the maternity department at NUH. And in the end, I had to stick the stickers on my belly with tape because they didn't stick properly and they couldn't find a heartbeat. And I was lying there not knowing where's my baby. The fact that you come here and expect women in Nottinghamshire to be grateful that you've now sorted out the fact that the rows of heart machines that were in your corridors weren't working and no one was keeping tabs on that, I find amazing. Because some of the things that you're telling me, like the community wives being linked up to everything else, I used to have to take, I was a high-risk pregnancy, I had to take my paper file to my community midwife and I had to tell them, I had to verbally tell them what a qualified consultant had said the week before. Well, I'm not medically qualified. I don't know if I'm going to miss something really important. And I carry there in the paper, oh, I can't quite read that right. What was your blood pressure? What was this? What was that? This, I'm not suddenly pleased that you've suddenly do that. Women have been telling you that about this, and I know community midwives have been telling you about this for years and years and years and years, and yet you expect us to be absolutely over the moon by it. I think it's great that you've done it, but it should have been done a long, long time ago, and it doesn't fill me with the confidence that you're making the necessary improvements to make women and babies feel safe in Nottingham. I really don't. And given the statistics, the data, and actually what you haven't said to us today, because actually what you would have been better have done to do today was to walk in here and tell us warts and all what happened with regards to that letter, with regards to inspection. You would have been better off telling us about the 15 minutes. You would have been better off telling us about what's going on in stillbirths at City Hospital. You would have been better off telling us about the £140 million, which you know about, quite obviously, because you said it. So you do know. And yet we've had months and months and months of you saying we don't know and we don't know how to get that information. And I lead to the conclusion that I will continue to say women and babies are not always safe in NUH. And this cannot go on. It cannot go on. As I said, I was talking to a woman in November and I am shocked. I still remain shocked at the treatment that is going on within your departments. You are not making the improvements. Maybe this inspection report will all come out singing and dancing and saying, you're absolutely great, but they haven't seen the data that we've seen. And even if we talk about the absolute basics, not triaging women every 15 minutes puts women and babies in danger. The fact that stillbirths have risen in the City Hospital and no one knows why, all these months after we've had the Hawkins case and all of those cases, and we're still having stillbirths rising in our hospitals, it's appalling. And I know, as I said, sometimes things don't go right. And sometimes things aren't in anybody's control. But when you walk in that hospital as a healthy woman and a healthy baby, and what should have been a really straightforward pregnancy, and it doesn't work out that way, There are two things that need to happen going forward, and this is with regards to the review as well. Firstly, you need to listen better to women when they come in. That's the first thing. That does need to improve even now. I don't believe you're there with it at all. I really, really don't, because these incidents won't be happening. And the other thing is, I think you really need to start being more transparent about what is and isn't going on, because everyone here, and I don't wish to speak for everyone, I know that Councillor Saddington, for example, we don't want to argue with you. We don't want to fall out with you. What we want is for women and babies to have the care that they're supposed to have and need and actually deserve. Sometimes I do find the way you talk about this is quite flippant. And I have a real passion about the fact that women's health is very, very, very important, and babies' health is very, very important. And I sometimes worry that this isn't treated with the severity that it is. And the reason that I worry about it is because of the presentation that you've given today. Because it doesn't highlight those things actually where you really need to improve. So I'll place on record again, and I will keep saying it. And the reason I keep saying it is because we ask for information and we don't get it. When we get the information, you only present to us what you want to present, and you leave bits out, and you don't highlight some of these serious things on these graphs. You don't highlight them. So I'll put it on record again. I don't believe that NUH is capable of making the improvements that it needs to make sure that women and babies are safe in Nottingham. I don't believe it. I think you've had years and years and years to do it, and it's not happened. And you've tried to present to us today improvements that actually are absolute basics of a maternity department. Answering the phone to women when they've got a problem, monitoring a heartbeat. This is the bread and butter of a maternity department. And then saying harm in the incidents have gone up, but we're now reporting them correctly. You're now reporting them correctly. You should have been reporting serious incidents about stillbirths all the way along. It should never have been that somebody has a baby that dies within your care and they have to fight for answers. They have to stand up in a court of law and go through one of those traumatic experiences of their life. That should not ever, ever happen, and I don't want it to happen again. So I believe there needs to be intervention here. We've called for it before. I remain by this. This doesn't fill me with confidence. You need a public inquiry as to what is going on at NUH, and I absolutely stand by that. And I'm going to end with something really, really personal to bring it back to the humanistic side. My little boy was 2 years old on Sunday, and I spent some time in the morning while he was running around and opening presents and doing the normal 2-year-old stuff, and was going through some photos with my mother and mother-in-law, looking at the 2 years comparison. The fifth photo on my room is on my phone here. It's the first photo that I personally took of my child when he was born. The other 4 photos were taken kindly by an anaesthetist when I had to have my emergency C-section. The first photo that I took of my little boy, he has sick all over him, all over his cot. He has no hat on and he's not wrapped in a blanket. And he had been left like that for an hour and a half while I was told to rest. I burst into tears on my son's 2nd birthday because for 2 years I've carried the fact that I was a complete failure as a mother because I fell asleep when I was told to. And it's traumatised me. It has. But I walked out of that hospital with my baby and I went home and I celebrated his 2nd birthday with all my family. But I speak to parents on a regular basis where that doesn't happen. So on my son's 2nd birthday, I spent a period of that time feeling very, very sad, very, very upset. And actually even more driven to make sure that women and babies in Nottinghamshire are protected. And so talking today about maternity services and showing emotion about it is actually very difficult. So very personally, very, very difficult for me. But I will do, and no matter how difficult it is, I will keep saying it and I will keep talking about it, because I honestly don't believe that women and babies, when they walk, are necessarily safe in your care. And only a public inquiry, I believe, will get to the bottom of exactly what has happened.
Thank you, Councillor Welsh. Before you answer Councillor Welsh, I would concur with a lot of her thoughts. I think you are not listening to patients. You are not listening to staff. The very fact that staff cannot recommend going into Queen's Medical Centre is of great concern. They're at the front line and they're not recommending people to have births there, which is what I said in the very first meeting we had here, that I didn't think mothers were safe. Go and have a baby. Now this is really something, because when I was younger, I was told that birth was very easy, straight going, no problems. You read a report like this, and it just contradicts everything that I was. Now, the fact you're not listening to patients, they're the ones that are flagging up whether they think there's something wrong with their babies. That is number one importance. Number two, staff have actually spoken to me and broken down in tears because they feel they're not listened to and they don't know who to go to complain, because they daren't, because of their jobs. Now, if you haven't got happy staff, you haven't got a happy maternity unit, and it should be the happiest place in the hospital. I have had so many emails from patients telling me of the experience they've had at the hospital, and quite frankly, I don't get easily upset, but I have sat and sobbed. And one night I read an email, started to read an email. It was a Sunday night. And I thought, I can't read this tonight. I will never go to sleep. Now, it's not within our remit to deal with what they write and what has gone wrong. And all I can do really is write back and say that we as a committee are looking at these problems. And of course, I welcome these emails from people, although I personally don't have the remit to put it right. But I certainly have it within this remit to make it recommendations. But I'm like Councillor Welsh, and we've been in this since the beginning and we've been looking at it the same way. I don't feel that Queen's Medical is any safer today than it was a year ago. And to hear from staff that they daren't speak because they're frightened of their jobs, and to hear patients who are telling you that they've clearly got a problem that they feel and it's not being listened to, and then to receive emails from such sad cases that is unbelievable, it just breaks my heart. And that I have a grandson, I have great pleasure from him. And to think that these people who write to me are saying that 2 or 3 years on, they still haven't got a baby. After all, it may happen that you get one chance to have a baby, and if that baby doesn't live, that is the end of your family. And I feel very, very strongly that reading, well, in fact, there was something in the press, and it implies that they're thinking you haven't made that bigger progress. And it does matter to me, it matters to me greatly that you don't have these figures. Because, you know, Councillor Cubbley's alluded to again today, we need to know how many stillbirths, how many brain damaged children. These are babies that people have lost. And either you haven't got it in your work remit to find that out, or you want to push it away. And you cannot push those figures away. They are there. And they're mentioned quite often in the press. And I keep saying to my officer, how come they've got it and we haven't? And to me, it wants a fundamental review. It's the only way this will ever, ever improve. I shall be more than interested, as will my committee, to look at what the CQC say. But I have my fears that it will show not a very large improvement. And today we've got people going into Queen's to have a baby for a wonderful experience. And here we are, I think it was in last night's press again, of the problems. So as a chairman and as a committee, I am asking you to A, make quicker progress and go fundamentally down to your staff. Because if you haven't got a happy staff, you won't have a happy unit. There's no doubt about it. And also your patients who speak to you. They're not speaking to waste your time. They're speaking to wait because they're worried. And I've had emails to that effect. So I do really ask you to look, we're not here to fall out with you. We want to work with you, but we want to impress upon you that the emails, particularly I'm getting, Councillor Welsh is getting, you've got a lot of worried people out there. But Councillor, do you want to come back to us on that, or do you want to hear from Councillor Turner first?
I'm more than happy to come back
on
those things. I've tried to write things as I've gone, and I hear absolutely everything that you're saying, and I say I've been here since the end of June, and it's certainly been a baptism of fire. But I want to say that before I came here this morning, I was one of the ward's shared governance councils with the staff, so absolutely listen to them and their ideas about how they can change and improve. And after this meeting, I'm going to be late, but after this meeting, I'm going to see one of the families that has contacted me to talk about their experiences. So we are absolutely listening. Have we got it right? Absolutely, no, we haven't got it right. And listening to women I think is a theme that comes through a lot of reports, and how can we do that differently, better? And so we're using the mechanisms that we can. I think the CQC, their feedback was that they felt a real positive change in the culture, that staff they absolutely do come to talk to me, and I've been in tears many times around the stories I've heard from staff, because we care about our services, and the staff come because they are passionate about maternity services at Nottingham and they want to do a good job. Nobody comes to work to do a bad job, and it's just so tragic, and it's absolutely dreadful what's happened, and we have to learn and improve. And I absolutely understand what's been said around the pace of change, because I'm constantly frustrated with that. But when I haven't got the staff to be able to do that and to make sustainable change, I could tell people to do, we need to do that. It won't be embedded. It's got to be led by the staff themselves, to make those changes so that it's sustainable and it becomes part of our everyday practice. You've seen that the dashboard is absolutely a work in progress, and I everything that the councillor has said around it's getting the narrative right. So some of the cases, I think we're looking at, it's one case, but the graph looks really dramatic because it's really small numbers, but those numbers matter. And I'm not decrying that one doesn't matter, because absolutely it does matter. So, I want to just pick up on a couple of things around certainly the triage part. So, CQC have come into City, and at the current present time on both sites we have triage, so which is our emergency ED for maternity, but we also have our day assessment care as well. And these are women that have scheduled appointments to come in, so they've been through either triage or to antenatal clinic, and they need to have either BP profiles or monitoring, for example, on a regular basis. So they have an appointment, but at the minute they're in together. So when we've been reporting on when they've been doing the audits around our 15-minute triage, what they've been doing is including everybody that comes into the department instead of excluding those that have an appointment, because that does impact on the figures. So we've excluded that, and actually I can report that we had 93% were seen within 15 minutes. So that has massively improved. It's about how we monitor. And I think, you raise a really good point around when we're really busy, we've strengthened those processes. So we've now got a flow coordinator. So this is a senior midwife who works alongside the labour suite coordinators to ensure the safety of the unit. So the labour suite coordinator has to concentrate on what's happening on the labour suite because that's our highest risk area. The flow coordinator is that conduit between the walls, between triage, and is a point of escalation as well. So they're reporting on a daily basis. I'm asking for a weekly report now around our metrics for making sure that we've got the 15-minute triage. And actually the women that haven't been seen in 15 minutes have been seen within 20 minutes. And what are the consequences? Have we triaged them properly? Because once you've been seen, you go into either a red, amber or a green category. And green actually means you can wait for 4 hours to be seen. And that's absolutely appropriate and fine because that's clinically indicated. But, have been escalations when there's needed to be. What are the staffing? So all of those things are pulling together. And I think, the CQC I've called that out as a concern, and it's just around how we've monitored that, and that is progressing. So the 4th of April, the day assessment, the care will be taken out of triage and moved into different areas and staff separately. So that's going to be a massive improvement. But the first part is around our maternity advice line, which is our first point of triage, where women are assessed via telephone. And then appropriately advised or told to come in as well. And that is something that no other trust has got. So I put a call out to, part of a network of other directors and heads of midwifery. And other trusts have got a triage line 10 till 6. Well, we've got one 24 hours a day. So, there are things that we're doing in Nottingham which is so different to everywhere else. And part of that is from incidents and issues that we've had and how we've responded to them. And going back to the emergency cesarean section, I mean, we need to move away from having cesarean sections as a target full stop. We need to get into this language of safe births rather than comparing figures. And actually the more meaningful is around what we call Robson groups. So again, this is 7 categories, I think 7 or 10 categories of women that we can say, well, actually this is a first time mum, she's 37 weeks and the baby was breached. That's Robson category 1, for example. So we can compare like for like, because actually if you cluster everyone that's had emergency cesarean section, there are different clinical reasons for that don't actually tell you anything at all. It just gives you a rate of cesarean section. But the national drive is that we absolutely move away from monitoring that. But you're absolutely right. It's about, is it an appropriate cesarean section? Could we have done something differently? And going back to the PPH, the presentation around the postpartum hemorrhage, we will always have postpartum hemorrhages. But what the key part for us is actually, is there anything that we can do to identify that woman's been a higher risk of postpartum hemorrhage and do something preemptive, like making sure she's got good iron levels? And if she does have a postpartum hemorrhage, have we escalated and treated her accordingly? Sorry.
Yeah, just for a point of clarification, with regards to emergency C-sections, my question was, are you monitoring how many of those emergency C-sections were actually what would be classed as avoidable, in the sense that a woman wasn't listened to, which was the situation in my case. My emergency C-section was completely avoidable, and if actually the midwife had checked my file and believed what my consultant had said, I would have gone into hospital there and then and not had to have an emergency C-section that put me at risk. Since being in this role, I've had 4 different women contact me with a very similar scenario, which is why I'm concerned about the triage aspect and why I'm concerned about the fact that emergency C-sections never seems to really lower. And you're right, it is really important. The most important thing is safe birth, because there are some organisations, for example, that push a certain type of birth, and that if you don't have that type of birth, then it's not as good as having a C-section. I personally was, when I found out I was having a C-section, was quite but that was just me. But it's that bit about the C-section bit that I'm really want to make sure that NUH has got a grip of, because what I would like to see actually is everyone having a safe birth, but the emergency C-sections reflecting those people that medically, that is out of control, out of anyone's control, having an emergency C-section, not someone having an emergency C-section because they haven't been listened to in the first place, or they've not been able to access the care that they need to initially. And that's a massive concern for me. So it was just whether NUH had got a kind of grip with regards to around their emergency, because I think that does reflect on the health and safety that's going on within the department as well, and some of that triage aspect as well, whether it's over the phone, because that's the other thing about the phone situation. How are you evaluating how that is going with regards to who's phoning in, what are they advised to do, and what is the outcome? Because that's the other thing. You can say to us, oh, we speak 24 hours and we speak to like 30 women a day. Well, how many of those women are given the appropriate advice and given the appropriate health care within that time frame? That's the important thing about the advice line. And I take it that you're one of the only trusts that have that, but other trusts do answer their phone when women phone the maternity department quite quickly. So they don't necessarily need the 24-hour phone. Just because they've not got a 24 advice line, they're not ignoring women when they phone them up at 2 or 3 o'clock in the morning. And the other thing that I'll say about NUH, which I didn't raise before, is if you look at some of your statistics and some of your data, some of your biggest problems are in the night for staff and for things going wrong. So actually, you should have that 24-hour system and somewhere and 2 midwives talking it, because that is one of your biggest weaknesses on your maternity department, is what happens during your night, and the fact that there aren't people there for C-section, or in my case, didn't want to give me a C-section until the morning and were going to leave me. So I think, there is something that needs to be looked into and carried on with regards to these things that you're doing aren't, we've got a phone line and that's it. We need to know that people that are accessing that phone now, that it's actually benefiting the women, and actually not just stopping people going in for triage so you can meet that 15-minute thing within your hospital.
And that absolutely isn't the case. So if someone rings in with reduced fetal movements, for example, they're told to immediately attend. They must come straight in and we do that. I mean, just picking up, I can give again a real example of around the emergency cesarean section discussion and listening to women. So we have 3 times a week, we have a rapid review of our incidents. And there was a case last week with a woman that had a suspicious ETG. She was being induced. They decided that actually the best course of action was for that woman to go and have an emergency cesarean section. But actually, there was a delay because the woman wanted to have the time to consider and to discuss. And actually, then the outcome for the baby was that the baby was born in a poor condition initially, but did recover. But we did have that time, that half an hour, actually, that was led by the woman to say, I'm not sure whether I want a cesarean section. And those conversations with the doctors to say, well, actually, this is why we're recommending it, and it's really difficult when, the learning for us really around that is how do we have those conversations before she's in labour? Because, as ladies in the room that have had babies know that altered state that you're in when you're in labour. So actually it's about how you make those informed decisions before you are in labour. And that's a really difficult nut to crack for all maternity services. There's national work going on around something called I Decide, which is stalled, but it's something that I think every service is struggling with, being able to have that informed consent and choice when you are in labour. I think that's a real challenge. I mean, I've got other things that were raised, but I don't know if anyone else wanted to come in.
Thank you. I realise this is a long session. I'm going to ask Councillor Turner to ask his question, and then I think we'll have to draw this item to a close for today, but not for long.
Well, I think Councillor Saddington and Councillor Welsh has, excuse me, has covered most of what needs to be said. So if the care is improving, we should see a decrease in the claims amount, even allowing for historical claims. We should see a decrease in the claims. But I can't see a plan. I can't see where you're going. I can't see when you're going to get there. I don't, is that the case? I think there needs to be more openness, more transparency, and and targets. Thank you.
Okay, would you just like to answer that?
I've just come back on that one. So in absolute honesty, the claims data runs 10 to 15 years in arrears of the incident. And so if we're waiting to see if claims data are improving to show us whether we're improving now, we're going to be waiting a very long time because the legal processes take that order of time. So the claims data is a very retrospective look. The real-time look is on the dashboard that we presented, and Councillor Welsh has raised a whole number of really important questions around the dashboard, questions that we've been asking ourselves and that we are seeking to understand in more detail. The real-time reporting of our incidents and of harm and of outcome for babies today, that's what we're really concerned about. We absolutely welcome, Councillor Saddington, the opportunity to work with you. It is on all of our interests, and the people here are all very passionate about the maternity service as well. We want to be proud of the maternity service in Nottingham, and we want women to have an outstanding service. We want babies to have the very best outcomes. So there's nobody that's not, the things that you've stated that you want to see are the things that we want to see. So we would very much welcome working together on this. Clearly there's a lot to unpack from the dashboard, and I know that there's a number of councillors that are booked to come and have a visit with us, and I don't know whether there's an opportunity for us within that visit to sit down and take people through the data in rather more detail than we may have time for in this meeting. But we'd be very happy to get the right people in the room from the Trust's point of view to have an informed conversation with you about the medical approach, the midwifery approach, what the data is telling us, if that would be helpful to you.
Thank you very much. Well, first of all, I must thank you for coming. And I think the whole point of health scrutiny is that we're looking at it from a councillor's point of view, representing our residents. You're looking at it from an inside point of view, and it's the outside point of view that is so important because we can see it in a different light from somebody actually involved. Yes, we would like to make visits. We had to curtail those, obviously, during COVID. But I will be asking members who would like to make the visit, and Martin will arrange some dates convenient to yourselves, bearing in mind we've got Easter coming up and diaries are booked well in advance. But Sharon, what I would say to you, really, I'm very pleased to meet you, because when we started this in the beginning, we were told that, somebody new had just got a job. So from the committee, I am really saying that we are putting our faith in you to improve Nottingham Hospital. Nottingham Hospital, years ago, used to have the best name, I think, in the country. And I think if you improve, and you improve your relationship with your staff, it won't take long for the message to get around that the staff are treated well at NUH Hospital, and that's the place to work. And I think that will increase your staffing immediately. Who wants to go and work in a hospital where you've been rated inadequate? If you can raise your level and bring the standard of Nottingham NUH up to standard and beyond, people will be flocking to your door, because we see the other hospitals that are not succeeding. I have to say, I'm not particularly interested in them. No comparison to them either, which probably I should have. But I am interested in you bringing Nottingham up to the standard it used to be. And you will find, I'm sure, the word will get around that Nottingham are a really good hospital with good births, etc. And you will find you've got staff coming. They're not going to come as long as there's a name hanging over it that it's inadequate and making slow progress. And I think, we need to see a faster progress and happier staff, and I think you'll find that you automatically get staff applying for the jobs. So that's from me. Thank you to you all for coming today. We would like to see you when you've had time to break down the CQC report. Do you suggest that you would prefer July, or would you prefer the autumn, so that you can get your report together? So, Martin, I think we'll liaise with you on that, and we'll get a date where we can see, hopefully, some improvement. And I think I would ask again, because I'm sure it's possible, that we have the figures for stillbirth and the figures for brain damage children, so that we can look at it. And if you want, bring another hospital in to compare. But what we need to see as a committee is that breakdown, because to us it's very important. Councillor Welsh, quickly.
Yeah, very quickly. We found out as a scrutiny, well, I found out as a scrutiny committee with regards to the plans, with regards to new NUH, about the possibility of a maternity department merging into one. And as a scrutiny committee, I think it would have been really helpful for us to have been communicated that, rather than as necessarily hearing it in the media, because again, that sends alarm bells ringing when we're supposed to be scrutinising the maternity departments. So it's just a suggestion, is that once you do get the CQC report and you start telling stakeholders what the situation is, it'd be really useful that it wouldn't necessarily, I know these things happen very quickly, but it would be really useful if perhaps you sent it to Councillor Saddington and Martin, that could send it to us with regards to what you're communicating, with regards to the stakeholders, with regards to what is happening, because that will actually stop us from making perhaps some assumptions that we shouldn't be making, and give us the correct information. And I'm sure Councillor Saddington would be more than happy to, I think, to have it, and then, you know, pass it on as necessary to the scrutiny committee. I wouldn't want to just hear it from Notts TV or etc. Again, I think it would be useful from your perspective as well, as what, because we'll all read the report, but from your perspective as to what they're saying, so we get a very clear understanding of what is happening and what happens next.
So thank you very much. I'm sorry we've kept you so long, but hopefully we've all learned from it, including yourselves. Yes.
Can I just say a final word?
Yes, of course.
Look, we've heard some very personal reflections here in the council chamber as well, and you know, we're all wiser for hearing these things. It is our intent to make this the best service we can, but it doesn't always go right. Where it doesn't go right, we should apologise for that, and it clearly hasn't gone right in every instance here. We've heard some of that today, so please accept that apology. It's quite clear that we need to develop the working relationship with the committee, so that we're answering questions quite clearly that you want. And I sense we've gone a bit of a way down the track, but not far enough by some distance yet. So let's work on that, so that we can provide you with the insights that you want. And there's some complex data in here to interpret. So I think there's work for us to get to those points. I absolutely concur with you that understanding our staff's perspectives and listening to them, understanding our patients, and those are areas where we are getting some improving comments from us. And I'm sorry if the CQC representation didn't feel wholly balanced. It is in the public board meeting on the totality of the letter. So if it didn't feel that way, I'm sorry about that. I thought, you know, we've got to go a very summary position on it. We do know there's a lot to do. We absolutely know that. We're not expecting sea changes in our ratings in a short space of time. That absolutely isn't what we'll see. We know that. We'll see gradual moves along as we deal with this. But one of the things that I would reference is that when the CQC went round each day, the feedback from staff was how good Sharon's leadership was.
So our trust is in you, Sharon. Thank you very much, all of you. Yeah. We'll give you time to leave before we bring in Bassett Law. Thank you so much. Thank you. Thank you. Right, members, we knew that one. For Bethany, it's baptism by fire. And we'll move on to Bassett Law, and we'll then move on to tomorrow's NUH, which will be a brief. I shall ask for it to be a brief because some of you may have logged in yesterday and got the idea of it anyway, and then we've got to have more briefings. Good morning. No, good afternoon. Good afternoon. I'm sorry if we kept you waiting out there. We'll be succinct with yours. Right, well, good afternoon, and all of you. We have Idris with us, who's the Chief Officer at Bassett Law. We have Dr. Tim Noble, is that you, sir? Who's the Medical Director, and David Perdue, Chief Nurse at Bassett Law Hospital. You happen to be sitting next to Councillor Perdue Horan, but obviously not related. So, thank you for waiting, and I think you're going to be bringing us up to date with how you're improving and building your emergency services at Bassett Law Hospital. So we wait with interest.
Thank you, Chair, and thank you for having me back. So we'll try and get through this fairly quickly. I know it's a bit more pressed for time. I'm going to give a brief background, and then I'll pass over to my colleagues from Doncaster and Bassett Law Hospitals to provide sort of some detail and clinical view, and then I'll come back to talk about the next steps. The first thing I just wanted to cover was that I am conscious that we're in a PERDA period, because although there aren't any sort of immediate local elections nationally, the NHS and public sector is obviously under that PERDA period because of the forthcoming local elections elsewhere in the country. But notwithstanding that, I think this particular issue is already in the public domain. The £17.6 million worth of investment into Doncaster and Bassett Law Hospital was announced actually some time ago. But it's important that now we've concluded the consultation stage, which I outlined at a previous Health Scrutiny Committee, that we wanted to come back and obviously update you with the outcomes of that. And it's still our intention that the governing body, subject to this remaining a non-contentious issue, that we'll still be able to make a final decision on the model of care going forward at our meeting later in the month. So, as we discussed in a previous committee meeting, we conducted a quite extensive consultation sort of programme, and I'll go into that in a bit more detail. And this is really about the investment of the 17.6 million and how we can use that to improve urgent care services at Bassett Law Hospital. But it also included consideration of a number of different approaches about how we could do that. And it provided an opportunity for us to address the quite long-standing temporary change now in the paediatric ward, which had to be closed overnight back in 2017 due to staffing shortages. And one of the proposals in particular, we feel, and we were quite open about our preferred option when we went into the consultation. I'll come back to what the public felt about the different options. We felt that it did really provide an opportunity for a long-term solution for a much improved paediatric urgent care service going forward than what we currently had since 2017. So I'll pass now to my colleague David, who is going to describe the case for change and the different options. Thank you.
Thank you, Chris. Good morning, everybody. Oh, sorry, good afternoon, everybody. So in terms of the case for change, as an organisation, we're committed to providing accessible services locally. But however, safety remains our highest priority. In terms of the investment, that gives us an opportunity to co-locate our paediatric services next to ED, which would mean fewer specialist staff in terms of specialist nurses would be required, but would also benefit from shared teams across various sub-services. But the emergency department paediatric attendances continue to rise, so we do need to work differently. So we have looked at different models and actually how we need to work much closer with primary care and community services. But a new development and facilities that kind of have been, we've spoken to lots of staff and ways of working will attract new and experienced staff. The next slide, please. So in terms of the development of the options, we looked at a range of factors were considered, covering quality, access, affordability and deliverability. So we had significant clinical support from clinical colleagues in DBTH and within primary care, and also we're a member of the Children's Hosted Network across the South Yorkshire and Basildon ICS, which is hosted by Sheffield Children's Hospital. So we included views of families with recent experience of transfers, and our options we considered and discounted include discontinuing the provision of children's urgent services, and we felt that would not fit into our local and organisational need, and the opening of an inpatient ward, which would not be achievable with staffing levels. So we did brief Health Scrutiny Committee in November 2021, and triggering the duty to consult, and we consulted on 3 particular options. So the first one, in terms of option 1, was to continue the current temporary model, but on a permanent basis. So the existing children's assessment unit stays where it is, which is geographically distant from the emergency department, closes at 9 PM each evening, with no further admissions from 7 PM, and patients requiring overnight stay are still transferred to Doncaster Royal Infirmary from 4 o'clock in the afternoon. This option would mean that the unit would provide 10 assessment spaces for children and young people at Basildon Hospital. So the benefits of that, it maintains a stable position, the model is well established, and maintains the resilience of clinical oversight and delivery for paediatric nurse input. The risks to that is it fails to consider the opportunity for more patients to remain locally in Basildon, and patients might be transferred if there is a need for observation at night, and it's potentially a poor patient experience. The second option we put forward is a dedicated children's assessment unit is built next to the emergency department, but still closes at 9 each evening with no further admissions from 7 PM. And again, it allows for better use of specialist children's nurses, but fails to provide that more accessible local provision. The next option we looked at, which was the preferred option, was a dedicated children's assessment unit is built next to the emergency department, which will allow children to remain on Basildon Hospital site when they require a short stay for observation, which can be overnight. So children requiring more specialist care or urgent surgery who require a longer length of stay will continue to be transferred to the Doncaster Royal Infirmary site or Sheffield Children's Hospital. And prior to all the closures, we did transfer children who had a high dependency need or urgent surgery were always transferred elsewhere from the Basildon site. But it does allow for better use of specialist children's nurses and means children who require a short stay will be cared for at Basildon overnight. So this option, when we've modelled the need, would have 6 overnight short stay beds, 8 assessment spaces and a further 1 to 2 treatment rooms. So we could manage between 15 to 16 children or young people at any one time. So the benefits it creates improved resilience through co-location, supports children staying for longer at Basildon with reduced need for patients to transfer to DRI site, without compromising their safety or quality. There are some identified risks. One is transition of service from current temporary arrangement is dependent upon the building works, and completion of ongoing recruitment and retention of paediatric nurse staffing. In terms of mitigation, we've worked with local higher educational institutions, and we've seen a double the number of children's nurses being trained locally. We're also looking at a different model of children's nurses, and we've currently training our first 3 nurse associates, and we're also undertaking some international recruitment. So with all those 3 together, we do feel we can have a sustainable staffing model for option number 3. I'll pass you back to Idris.
Thank you. During the presentation, David and I are covering the slides, but obviously we've got Dr. Noble, who is here as well. We'd be very happy to answer questions at the end. I don't know, Tim, if you want to wait until the end, or if there's something you wanted to mention at this point. Either way. We'll crack on. So, in terms of the consultation itself, this commenced at the beginning of December, and obviously conscious of the Christmas and New Year period, we continued the consultation right through to the end of February. We wanted to seek people's views about their current experience of urgent and emergency care, but also the features that people wanted to see in terms of the environment of the emergency village, as we've called it, which is really about integrating the various aspects of urgent and emergency care across different specialists and different ages, and in particular what people's attitudes and opinions were with regard to children's urgent and emergency care services. Next slide, please. So we conducted the survey in a range of ways. We had an external company that has expertise in this area support us in this work, and it involves not just the CCG but colleagues from Doncaster and Bassetlaw hospitals. We had a survey that people could complete either in hard copy and put it in the post, or indeed online. But also we had meetings with the public, we had drop-in sessions, we went out to try and encourage people, for example, in Eastern European sort of communities that we have in Bassetlaw, so try and reach out to people who, whose voices aren't always listened to as clearly as I think, sort of they should. We tried to target as well people who had direct experience of urgency and emergency care, particularly around sort of care of children. We obviously used social media quite extensively, both to encourage and raise awareness, but also give people the opportunity to respond and provide opinions through social media. And there were various written submissions. Alongside this, we did carry out sort of opinions of other organisations as well. So NHS England and Improvement have a process by which they oversee potential service change, and also the clinical senators provided sort of reviews as well. I think some of that information is contained in the wider pack. Next slide, please. So the responses. We were frankly delighted with the level of response that we received. So about 2,000 people responded, the majority of whom, 1,750 approximately, actually provided a response through the online survey. And that was really helpful because there was free text there. There was quite a lot of information that we could distill out of that, as opposed to sort of people either putting posts on social media or so in other ways. So it gave us quite a structured sort of response. We had a range of other responses. Some of those are identified there. So face-to-face with parents and carers, and feedback through postcards and from stalls that we went out into supermarkets and so on to really try and gain the opinion of the general public with regard to the various options. Next slide, please. So the findings were pretty overwhelming for this type of consultation. So the vast majority, or a large majority of 70%, said that they'd used the A&E departments, and about 2/3 of those had actually used the urgency and emergency department with respect to children, so which was really helpful to get that direct experience. And 82% of those have taken place within the last 3 years. So it's current experience as well. So a very rich sort of source of information and opinion. And overall, 85%, I'm very pleased to say, were very happy with their treatment, whether they were children or adults, and the quality of care that they received at Basildore District Hospital. Of the 3 options that David's highlighted, the vast majority, 82%, were in favour of the third option, the one that we'd actually suggested ourselves was the preferred option. They also said that what they wanted to see was the timely access to clinical treatment. Really important that there was good availability of staff, and the right staff, I would suggest, but also that the surroundings were sort of comfortable but inclusive of neurodiversity, sort of issues as well. So this helps us in terms of not just the planned option of care, and I'll come on to it in a second about what the respondents felt about that, but also the physical design, sort of the urgent and emergency care village. So I think in terms of getting a patient's sort of public's opinion, it's been really valuable for us to get that range of views. So next slide, please. So in terms of those options, the overwhelming 88% of respondents opposed option 1, 82% opposed option 2, preferred option, as I said, 84% supported option 3. So this is co-locating children's emergency care within the A&E department as a permanent facility, with access 24/7, so 24 hours a day, 7 days a week. So that was, I think, pretty conclusive. Next slide, please. In addition, sort of this rich qualitative experience and things that they wish to see, and things that also concern people. People really wanted to access care 24/7 locally, and I think the proposal does support that far more. That they were concerned about the negative impact on travelling further, particularly where it was travelling for routine, what was, and that there needed to be continuity of care, and that included familiarity of staff with their environments and so on. It was recognised that limited resources needed to be used wisely and effectively, and that there needs to be really safe and consistent care. But Basildore residents, and this is no surprise to either us or I'm sure yourselves, they want a comprehensive service at Basildore Hospital, and they want to have confidence that that's going to remain for the long term. And I think this £17.6 million worth of investment in the urgent care service at Basildore will do just that. Final slide, please. So the next steps, obviously we wanted to come to Health Scrutiny Committee, and I'm pleased in terms of how the timing has fallen this time, because our governing body meets later this month. There was a meeting actually as we speak with NHS England to follow this up, and we've had the view of the Clinical Senate, so the timing works well, because I will be able to pass sort of any views and comments from the Health Scrutiny Committee to our governing body before it makes any final decision. And that final decision is expected now to be made sort of toward the end of the month, last week in April. And our commitment as well, having had such a rich response, is that we will continue to involve the public in terms of both the design, but also sort of in future matters as well. And that we will be publishing sort of that full set of results of the consultation sort of very shortly. And that will be available to everyone in the public ahead of our governing body meeting. And that the links that we've now made with patients, with carers and staff in the development of the urgent emergency care village will continue through the development of the detail of that, through the implementation, and indeed afterwards in terms of the impacts and the impressions that people have, whether it truly has made the difference that we and the residents of Basildore sort of are hoping and aiming for. I'll pass now to to Dr. Noble for sort of final comments and observations. Thanks.
Thank you, Idris. Thank you, everyone. So I think you see from this that our consultation has provided us with a very rich data set of opinion of service users and recent service users. Their views are very strong and very clear. There's overwhelming support for our favoured option, which I think is reassuring to us that we're on the right track. And I think we really are on the right track. It's a really exciting opportunity, not just for paediatric emergency care, but for much wider health benefits for the population, enhancing our emergency front door. And I think we know now that if we are able to progress through with option 3, we will improve our offer for a wide range of paediatric presentations to the Trust, accepting that we are very fortunate in being fairly close to a specialist children's hospital. Not every town in the country can say that, but we are, and we have always needed to transfer some very specific patients to Sheffield, and we'll continue to do that. We will also, of course, take out some of this negative impact of the travel to Doncaster that we've had to be doing in this interim measure at the moment. So I'm really pleased that we've reached this point. The data we have got from the public consultation is actually really hard to get in other ways, and it's quite an exciting prospect to hear the volume of information we got and the depth of it, because it's more widely applicable for us as an organisation. There are some key things in there, simple ones such as Wi-Fi. Okay, so it's part of our life, but it's really important that we acknowledge that that's a key thing for people visiting our institution. So I think this is now a conclusion to the understanding of where we should be going. I think it's offering so many benefits to us and to the population, and I can see that if we can succeed in getting through the potential risks of going through with option 3 and mitigate for those, then we'll produce a much better option for the public and for paediatric care in Bassetlaw.
Thank you very much, gentlemen. Do we have any questions? Councillor Bailey, Councillor Guilfoyle.
Thank you. So I think for many of us who are in Bassetlaw, potentially around it, knows the impact of the hospital. And I think we speak for everyone when we say this consultation doesn't surprise any of us. Whenever you go out speaking to people, it's always we want access to care locally, as local as possible, and it's about the children's ward. Now, I'm very pleased that this consultation basically says what everyone else was thinking. I'm very pleased that you've decided to take on board the rest of what other people are saying as well. So the comments about Wi-Fi, as well as I read about the feel of the new emergency village, essentially, and making it bright, etc. So I very much welcome the consultation, and I welcome the investment that's going to be coming as a result of the government. And I really, really do hope, I don't want to be a bit negative about this, but I do hope this puts to bed Labour claims that the hospital is at risk. You don't have to comment on that at all. But I do hope it puts to rest that Labour, that every single election they go around telling people the hospital's at risk. This is investment that's coming in. Let's be positive about it. Let's welcome the fact that we're going to be seeing an increased service as a result of it. Potentially moving on now, I really do hope this is the baseline for future consultations as well. I know we had the comment about the mental health service. Let's hope that this sort of in-depth consultation carries on in the future. That's all the comments I'd like to make. There's not really much else to say about it, but thank you.
Thank you. Well, that was a compliment to you there. So, Councillor Guilfoyle.
Thank you, Chairman, and thank you for giving me the opportunity to speak today. It's nice to see Idris again. I'm sure he knows the road here better than most nowadays. Just a few things, Chairman. One is, whether my colleagues or others will point out that there are difficulties within the NHS and continue to do so. And if you take into the fact that we've just seen the mental health unit removed from Bassetlaw, I believe stroke victims are now transported through to Doncaster, and we've also got, the children's health. So there are concerns that Bassetlaw could become a cottage hospital, which is not what we want. So I think, it's quite right and proper for politicians and the public to speak out when they feel that their services are being reduced and their ability to get them. If our colleagues disagree with that, then clearly they're not listening to what the public are saying. Chairman, just in relation to a couple of things. One is, I was interested in when you opened, you talked about the fact that the emergency paediatric cases are rising. I just wondered what the thought was behind that and whether there was more that could be done in reality about education. I remember myself going to see a consultant paediatric from Leeds who explained to me about a child who had been injured, scalded actually, by pulling a cup of tea towards them. The parent had got the baby on the knee, having a cup of tea, and the child went and pulled the tea cup all over, scalded. They actually then showed you sometime later with some water doing the exact same exercise, and the child did exactly the same thing. And clearly that was to demonstrate that actually when people say, well, the kids will learn, don't put your finger in there and they'll not do it again, it's actually pointing out that they will do it again. And it's up to you as a responsible parent to sort of take more care around them. But I just wondered what was the background to that? Is it the fact that we've had in Bassett Law an increase in birth rates, so there's more children, so therefore the number of opportunities unfortunately grow for things like that? Or is it something different that we need to learn from? I think actually as well, the people would have liked a fourth option. And that fourth option would be actually that the eye dependents would stay within Bassett Law as well. And I think that's would have been the ultimate aim, but I can understand clinically sometimes why you make those decisions to send people to Sheffield, for instance. But clearly I'm sure, just saying, well, we're going to have a 24-hour bed, that I'm sure lots of them would sooner stay a lot longer in a local hospital rather than travel. So I think that, that fourth they would have possibly liked that, and I think you would have got, 99% of people saying yes to the fourth option if it had been put forward. Welcome the 17.6 million, but in reality it's bricks and mortar. What concerns me more is actually the biggest issue that's facing the NHS, which is staffing. We've heard it earlier on in relation to the maternity unit in the NUH, and the same is happening right across. And what I would ask is, what revenue commitment is being given to enable this to staff for the adequate staffing? Because clearly the reason why the original move was made was because we hadn't got adequate staffing of the right type, calibre, etc. So therefore the decision was taken to close it overnight. If we haven't got that, then clearly it doesn't matter how much you put a building up. If you haven't got the people to put in it, it's of no use. We'll just have a nice building and so be it. So what we're doing about the staffing issues, because that is clear to me, that's one of the main things, and the sustainability of that. Clearly, also not just midwifery, but not just nursing, but we also need, in reality, consultants to back that up, because that again was one of the issues that was talked about at the time, was that because of the density and the numbers, that throughput that we got in Bassett Law, it didn't actually pay for a consultant to be on site at the time, and for specialist nurses to be there. So what difference is that going to make? Because clearly what I don't want to see is a brand new building put up with all the intentions of, being the right intentions, and then you come back and say, well, actually, nothing's changed. We can't move children into it because we haven't got the specialist people to manage that setting. And also, I'm glad to hear that you're going to continue to listen to patients and to the public at large about what they want. I think it is important that there's that ongoing dialogue, not just when it's built, after it's built, and as we go on. Thank you, Chairman.
Thank you. I'll pass to David about the paediatric numbers and about some of the staffing issues, but I thought I'd just sort of make a couple of sort of observations. First, I mean, first of all, the option 4 that doesn't really exist. Yeah, we recognise that, and it is recognised in the consultation as well, that there were people who said, well, we don't like any of the above. We still want that, what they see as the pure, the sort of the full, sort of thing. But I think what the consultation has shown is, we have all difficult decisions to make in the public sector, don't we? And so from a health point of view, we have to balance, well, what's the best use of taxpayers' money? What's the most efficient way of providing things? How can we provide services that are increasingly specialised and make sure that, we provide the best of clinical care as well as the most, sort of convenient care? And how, as part of that, can we sort of recruit and retain the best and most skilled staff? And I think, hopefully, I do feel this is true, we've managed to get across a balance of this and how that applies to a local district hospital. And I think it's important that, as a clinical commissioning group, we're making clinical commissioning decisions that have to reflect what the public wants, but at the same time, we're trying to get across what we're trying to weigh up in reaching sort of final decisions. And I hope that the consultation that we carried out on urgent care and paediatric care, has done just that. And I think people are, when you're very open with people, they're pretty realistic. Sort of people are pretty sensible, and they recognise, sort of the challenges and the difficulties in not being able to have everything everywhere. But they still want, good local solid services that are available. And I think we've managed to use 17.6 million for the infrastructure bit of that to facilitate a better model of care that meets those different criteria. We are still trying to manage expectations, that 17.6 million isn't a new hospital, sort of it's not a huge, sort of developed in that sense, but it's a key, really fundamental development that will give us long-term stability for urgent care services and paediatrics. So we're trying to use the money in the best, most effective way as possible. And I think generally that the population will sort of recognise, so that's the case in this instance. But on the paediatric numbers and staffing, I'll pass to David.
Thanks, Idris. So in terms of the model, because they're co-located, we can use the staff a lot more effectively. And if you look at attendances for children coming into the emergency department, that drops dramatically after 10 o'clock at night and is virtually non-existent after midnight. So actually we can utilise the staffing much better, because the 6-bedded unit is virtually, well, ED's there, that's here. So we've got a much better model of that. So in terms of when we had to close the unit due to the staffing, obviously our workforce planning is much more effective now. So we've got new roles. So nurse associates are a new role. So actually you train for 2 years and you can stay at that level, and you're a different band, but actually you're a registrant. So we actually hadn't used those in paediatrics before, but we are now doing that. And we've also seen, obviously, all organisations have had international recruitment. And we're just about to start our first international recruitment for paediatrics. So the OSCE Centre, so the training to ensure they've got the right skills, is in Sheffield. And we have our first 5 international paediatric nurses, which actually takes our current establishment at Bassett Law to being fully established for paediatric nurses. So, and then the other thing, I lead workforce for the ICS in terms of nursing, midwifery and AHPs. And so we have worked with the HAIs to train more paediatric nurses. And we're also looking at having a conversion course from registered adult nurse to paediatric nurse as well. So by the time this is open, and before it opens, we will have the right establishment, which we believe in terms of the evidence is actually very sustainable going forward. Just in terms of the increases, so increases in terms of attendances, if you know Bassett Law, I mean, it's grown dramatically, hasn't it, in terms of new housing and everything else, which obviously means more people. But part of the model is working with primary care and our community provision to actually stream people off as they enter the emergency department for an alternative, whether that's kind of, they see a community nurse, community paediatric system. So actually we're trying to educate people as they enter the department in terms of alternative provision across the area.
Thank you for that. Councillor Turner and then Councillor Welsh.
Yeah, thank you for coming. Councillor Turner from Worksop South, so quite interested and very pleased with the great news. Very simple, really. Can you give us any idea on projections for the start and completion? Thank you.
So completion is planned to be summer 24, all things being equal, but we will start as soon as the business case is approved. So you'll see some tarpaulin go up across the corridor, across the front car park. So the new department comes out currently where the big car park is at the front of the organisation. So the outline plans are all drawn up. It's just sort of kind of doing them. So the elements that need to be co-located are all being looked at now. So we will be ready to go in terms of those plans.
Thank you. Councillor Welsh.
Actually, Councillor Guilfoyle said much of what I wanted to ask, but just a couple of things really. One is to say fundamentally about the fact that I'm really pleased that the community health services are exactly that, and I think that's really, really important, especially for an area like Bassetlaw. And I actually differ in the sense that I think the community should continue to have a voice with regards to if it's health services, and whoever's there, whatever political party or political colour, if they're going to stand up for those services, and I think that's wholly appropriate. But just to go back to the paediatric care and just give it from perhaps a mother's perspective, being able to go somewhere locally where your partner can then drop things off, even simple things like that to people's normal life. I've had an unwell child on numerous occasions to A&E just to be checked over and have these obs done, and there are many parents like that exist in Bassetlaw. Nip into a localised hospital is actually really important. What I was wondering, and I apologise if I haven't picked up at this in the report, it says the possibility of having the overnight stays. How many beds is that, and how do you cater for parents as well that are staying over with those children? Because the other side to that is that sometimes you just get a chair, which is fair enough. I know my little boy was spread eagled on this really big bed, and I was on this little chair, and I thought, something's gone wrong here. But yeah, it's how we take care of the parents that are in there. And the other thing, this sounds really basic and really trivial, but it's things that come up later down the line. But I know, for example, in the maternity department, if you're an adult with your child, you don't necessarily get fed, and yet there's nothing to get food after a certain amount of time. So it's parent care as well as childcare, because as a parent, the emotional factors with regards to it can be really tough, as you will all know and understand. But also, you need to be full fitness to be able to look after your child, to help the doctors and nurses to be able to do what they need to do as well. So it's that whole holistic approach to how we care for them as well. I'm happy for you to give me that answer outside because it's more the work that I do with women with regards to healthcare for their children, but it is something that is consistently raised by people that have a child that has to go to a hospital on a regular basis.
Yeah, absolutely fine. In terms of the current system, obviously ED is open 24/7, but we have an assessment unit that's currently got 10 beds. So actually, if you're staying overnight with your child, the child has to be transferred to Doncaster. So this model allows those children to stay overnight. So in terms of the design of that, we are going to co-produce it with parents, and obviously any build now looks very different to how the historical department looks. So there'll be twice, probably some of the cubicles are 3 times the size as they are currently. in terms of modern design and how we can derogate some of that, but actually there will be obviously parent facilities within the department, which is really important. Just in terms of the other question we didn't answer properly, in terms of medical staff, we've never changed the medical model. So the same number of doctors are on site as the ward was open as are still now. And we have to do that because of any child being sick coming to ED. And we obviously have an obstetric-led maternity site at Bassetlaw. So actually the medical model's never changed.
Thank you. Councillor Eddy.
Thank you. Just a really quick one. My little girl, she's 2. I had to take her to A&E quite recently because she fell and cut herself here. Not Doncaster, I have to say. Can you just make sure there's parking close? Because carrying a very, very, very poorly, quite anxious little girl in quite far I had to travel. It's really, really hard. So is there adequate parking near, and will there be child spaces as well? Because getting push chairs and everything out the car as well, it does make it quite hard.
Yeah, that's all been considered. Big parking's a big thing with anything we do. It's always the first thing people mention. So absolutely, there's drop-off areas where you absolutely can drop all those off. And actually, Bassetlaw, in terms of its parking, is very proficient in terms of what it supplies.
Well, thank you very much, gentlemen. You seem to have had a very successful survey. To have 2,000 replies is pretty good, because often in surveys we don't expect big numbers. So I think you've had a good survey. I think you've made a good decision. Would the committee agree with that? That option 3 they consider to be the best? I think children don't want to be taken away from home, and they do want to be kept locally. And I think you've probably come to the best decision that you can. Obviously, nothing's perfect, but that is a very good decision, I would think. Do the committee all agree? Yes, we're all in agreement. So good luck with it all. And just to say, we will be making a visit to you sometime. Not imminently, but Martin will be in touch later in the year or early next year, and we'll come and have a look. How's the mental health going? Just before you go, Idris, did we ever get a travel plan working?
They've not moved yet, so there has been a slight delay, largely because of the building work that needs to be done in the new facility. So I think we've been in discussion with Martin in terms of programming our return as you'd requested at the last
Okay, that's
meeting.
fine.
So
We'll see if you've got a travel plan up and running then. You won't get away with it. Thank you, and thank you, gentlemen. We are running very late, so we're going to have to make the next item quick sticks. Would you like a 2-minute break, 3-minute break? Yeah. Nathan, could you just the screening for a few minutes? We're just taking a short break. Thank you very much. Thank you. That was very pleasant for you, Idris, wasn't it? To be entered, yeah.
I like my job because when you go home, you know you made a difference.
Because it's just happy. It's nice knowing it's a very rewarding job. Very rewarding when you've helped. It could be like the tiniest thing that you've helped someone with, but it's like massive to them.
Just generally making that difference, because like I say, some people don't see anybody, or they've got a son that lives 40 miles away that comes on a Wednesday, and that's all they see in general. And it's just nice that you made a bit of a difference to them, conversation, chat.
They are brilliant. Richard the carer there, and Leah, the carer there. They are absolutely brilliant. I can't fault them.
It can be a very stressful job, but on the other hand, you get more rewards out of it than you do stressfulness. And it's nice to go into a service user and smile at you. You made the day. If they walk in and they smile at you, you know you've done something right.
I actually did something completely different before, but because I looked after my grandma a lot, so it forced me to go in and help other people. So if I could do it for my grandma, I'd do it for everyone else. And best job I've had so far, to be honest.
Come in and I might be feeling a bit low, and Richard will say, "Good morning, Doris," and I'll say, "Good morning, Richard, good morning, Leah," and I might be feeling a bit low, and then all of a sudden, them just saying them words, "Good morning," and "How are you today?" and they cheer me up. Really, really lovely.
It's like a lot of people, I think, "Oh God, Karen, I couldn't do that," but community is so much different. Like, some people will just go and see it to have a chat with them because they're lonely and they just want to see someone through the day. It's not all just all physical work. Sometimes it's social and interacting with them. It is quite flexible. I mean, I don't have to dedicate. If I wanted to dedicate my life to it, you can, but you don't always have to as well.
Sometimes I feel like I could put my arms around them and cuddle them because they're that good. And anybody that says they ain't, come and see me, I tell you.
I'd suggest we just. You haven't got more. I'll let them know you didn't notice.
Thank you very much, and thank you very much for giving this opportunity to share with you what we sincerely hope is a fantastic good news story for health and care services in Nottingham and Nottinghamshire going forward. Now, in the interest of time, I'm probably going to skip through some of the background to where we are and just talk to you about the proposals, but clearly if at any point you want to interrupt and get a bit more context, please do so. So I think Alex, you're just going to introduce this first slide, aren't you, and explain that we are currently in an active public listening process.
So yeah, just to say, colleagues will have had a copy of our engagement document and a link through to the survey that you can see there. That was circulated to all members on the 7th of March when we went live with this process. But Lucy's going to take you through the details of what's in that document and those proposals that are in front of the public right now.
Thank you. So just to reiterate really that what we're sharing with you now is our current best thinking about the key service changes that we can make to benefit from the significant investment that we hope to receive for the programme of work called Tomorrow's NUH. I would just reiterate that at the moment this is our best thinking, it's evidence-based, and it is informed by what we believe will provide the best quality of care in the future. But what we're going to share with you today are only proposals. They have been developed taking account of citizen feedback. We aren't in formal public consultation, so this is part of our process in terms of getting intelligence from our citizens and people like yourselves to make sure that what we do, because we do reiterate this is a once in a lifetime opportunity, will make our hospital services work best for all of us who are indeed citizens ourselves. So I am just going to skip through this background. So it is a major project, and it does provide a once in a generation opportunity to secure investment to upgrade and replace buildings on the City and Queen sites. But I would also say that while City and QMC are a large part of our overall health system in Nottingham and Nottinghamshire, they're not all of it. So any changes we make to our hospital sites, we know will have an impact across wider health and care services and how people access these. So whatever we do to our hospital sites must be connected with how we develop our GPs, our community services, our mental health services, and also our other hospital sites in Mansfield, Newark and Bassetlaw. And to reiterate, we want to keep hearing from the public how all of our system can work together. So the money that we spend on the City and QMC sites complements, not detracts, development of the rest of our health and care system. So we could just move to the next slide. Martin, I'm not going to dwell on this, but we shared some thinking, our initial thinking with the public back in December 2020. Since then, our thinking has developed, taking account of what our citizens told us, what we've learned through COVID, and also the national guidelines and rules that are around the programme. So some of what we're going to share with you now is very similar to what we shared with the public back in 2020. Some of it is developed thinking. Click the next slide, if that's okay, Martin. Thank you. We've developed our thinking with the benefit of expert advice from doctors, nurses and other clinical experts locally, but also further afield across the Midlands. We've used this additional expert advice to develop our plans in more detail. And I just want to be very, very clear that whilst this is spending money again on hospital buildings, our core purpose here in everything we do is to reduce health inequalities, to deliver the best health and care services for everybody, whatever their circumstances. But obviously another obligation that we have, whilst we hope to get a significant capital investment from the government, we've got to make sure that the new buildings that we build, as well as being safe and effective, are affordable to run. So we've also been through a process of making sure that our plans are affordable. So I will now get to the detail on the next slide. And what I'm going to do, I'm going to take you through two bits of detail. I think it is really important this is shared with you in a meeting like this today. And I'm going to start by talking to you about the Queen's, and then I will move over onto the City. So if we start with the Queen's, just to say our intention for Queen's is as far as possible that all emergency care will be provided from this one hospital site. And this will mean that all of the essential backup that people need when they need access to urgent care, will be there, ITU, laboratories, high-tech diagnostics, and all the expert staff. And by concentrating all of our emergency and urgent care on the Queen's site, it will reduce transfers of acutely unwell patients between City and Queen's. What this does mean, because what we're here to talk to you about really is where we feel that changing services will be for the overall population health benefit. It does mean that there is some urgent and emergency care currently provided from the City Hospital that will be relocated to the QMC. Now, examples of this would be things like acute respiratory care, so care for people, for example, with serious consequences of flu or pneumonia who may be admitted to the City Hospital. They will be admitted directly to Queen's, and also burns and emergency plastic services care, which has been provided at the City campus for many generations, will be relocated or would be relocated to Queen's under these proposals. Just to finish on emergency care, so that's really consolidating the Queen's medical site as our main emergency site, but we have also learned a lot about how people access urgent and emergency care through COVID. So we're not just looking at how we provide urgent emergency care from our main emergency site. We're looking at how things like 111, the urgent treatment centre on London Road, and also our GP surgeries provide part of that network of urgent care. And we do think we have to look at it as a network, because we do know that the way that people are accessing and requiring urgent care is changing, and we need to be flexible going forward. Just very quickly on this point, so we will retain some capacity to undertake non-emergency planned operations at QMC. And this is a pragmatic decision, really, where we've got standalone, high-quality facilities from which to do that. We see no need to change them, and that is predominantly the treatment centre and also the ear, nose and throat centre at QMC. We are suggesting some changes to the way inpatient cancer care is provided, and QMC would become the primary base for inpatient cancer beds, and this will mean moving some inpatient cancer from City to QMC. But as I'll outline next, it will still be possible and very likely that you'd have planned surgery and treatment for cancer at the City Hospital, but when people are acutely unwell with symptoms of their cancer and need to be in hospital, we want to ensure that they have easy access to the emergency specialist backup, which will become increasingly important with the development of new and cutting-edge developments. So we do believe that rather than focusing on whether we could put cancer on one site or it's better provided on two sites, what we should focus on is how we get people really fast access to the latest treatments. And then we know that the numbers of people diagnosed and living with cancer continues to grow year on year, and that's a good thing. We're ageing, survival treatments are better, survival rates are better. So we believe that by providing cancer from two sites gives us the best opportunity to respond to changing population health needs. So planned cancer at the City, urgent consequences of cancer at Queen's. And we know we can't predict what cancer is going to look like in the next 10, 20 or 30 years, but we think by configuring our cancer services in this way, we'll be best positioned. We are already, and we want to build on our reputation of being at the forefront of cancer research and innovation in Nottingham. And having close links to the University of Nottingham research expertise is really helpful, we believe, to help us train and develop our workforce to be the best. So I think probably recognising the conversation that you've had earlier in the morning, I want to describe, and it's described in the papers that you've had, and it's been described in the information that's been shared with our population for 2 or 3 weeks now. A proposal that we think will be of great interest to our citizens and yourselves is that of co-locating all family care services on the QMC site. And just to be clear, by family care we mean maternity, neonatology, fertility, paediatrics, genetics and possibly gynecology. And we do recognise that this is a significant change for our population because we currently have maternity services and neonatal units on both sites. The reason for suggesting we should bring all family care services together on one site at QMC is simple. We want to be able to recruit and retain a workforce of specialist health and care professionals that can provide the safest, highest quality and most clinically effective care possible to all our current and future parents and families. And our overwhelming clinical evidence tells us that this is the best way to do it. The proposed family care centre at QMC would, well, it's clearly hard to predict at this stage because these are proposals, but our hope is that it would be a brand new, fit for purpose facility that patients, families and staff could be involved in helping to design. We recognise that family care needs to have a very different ethos and environment perhaps to a busy acute hospital. So it's really important that we how that facility comes together is informed by the people who have and will use it. Just to reiterate, all facilities for children and young people, including children's A&E, neonatal and paediatric intensive care, which are currently in the main hospital, would be in the new family care centre. And whilst hospital births under this proposal would only be possible at QMC, families will still be supported to have a home birth if they choose. And we will ensure that community-based midwifery services work seamlessly with hospital care to support families pre and postnatally, and that therefore offer the best birthing option for each individual and their family. In the interest of patient choice, whilst there will be, under these proposals, there would be only one option for hospital births, we'll continue to provide a choice of locations for antenatal and postnatal care at both City and QMC. And we'd like to think in other community locations going forward. And we will also work with our GPs and community services to ensure that children don't come to hospital for care that could be provided closer to home. So probably to finish on this change, I want to be really clear that the work to improve maternity care services, including the independent thematic review of maternity services at NUH, will continue to be a priority for all of us, separate to the development of the changes proposed here. However, we do believe that these changes will help support the journey to improving safety and quality of family care services. So, the City Hospital, I want to be very clear that this concentration of services at QMC will not detract from the City Hospital. We've got major ambitions for the City Hospital, and our vision here is to transform it into a centre of excellence for planned care. This would enable us to protect capacity for planned operations at times when emergency care is very busy, as it is again now, but also help us maintain the highest quality of emergency services at QMC. So we're looking at this planned and emergency care separation, and there's good evidence to suggest that that does help you protect your planned capacity. We would be, as well as high volume specialties, so specialties where we have a lot of activity like orthopaedics, we'll also want to continue to build on the excellent reputation of planned cancer care services at the City Hospital, which has been built up over many, many years, indeed many generations. And so for specialties like urology, breast and lung cancers, patients will continue to go to the City Hospital for their diagnosis, their surgery and their outpatient treatments like chemotherapy and radiotherapy. We would see no requirement and no benefit from changing that, but only if they were acutely unwell as a consequence of their cancer treatment and they needed that specialist emergency backup would they be admitted directly to Queen's. The Maggis Centre on the City campus will continue to provide the invaluable support to patients and their families living with cancer. So again, that concentrates that sort of holistic support on the City campus. And of course, as treatments improve and patients live longer, we believe that cancer will become a long-term condition. We'll build on networks between hospitals, GPs, community providers and the third sector to work together to provide the majority of care for people with cancer and their families outside of hospital settings. As well as increasing our throughput of planned care through the City campus, we want to offer more in the community where that's appropriate to do so, because we know there are planned care interventions that you don't need to come into hospital for. And we do want to make more use of remote consultations through deployment of digital technology and phone consultations where people can access care this way. But we absolutely recognise the risk of digital exclusion, and we will tirelessly to overcome that and ensure that we have suitable alternative ways of providing care for people who aren't able to access remotely or digitally. So that's just my sort of summary of the main changes on the two sites. And if I just wrap up now by telling you what will this kind of all mean, if you could move to the next slide, please, Martin. So we will see major investment that will mean that our hospital sites offer modern new facilities. Some of our current buildings will be refurbished, some will be replaced, and we will also make use of the best and most up-to-date medical and information technology. Whilst this is about health hospital services, I think we would all acknowledge that a massive investment like this in Nottinghamshire should create benefits. So we think it should generate skills, opportunities for people to develop new skills. I mean, a huge construction project, we might be able to train a generation of apprentices, and we certainly would want to leverage our medical technology skills growth in Nottinghamshire on the back of this. So we believe that this investment will bring wider social and economic gain. But I just, again, want to reassure you, this money is to make our hospitals fit for the future. But that doesn't mean that we won't continue to invest in our other health and care services. And we know that the legacy of the COVID pandemic places an even higher obligation on us than ever to address the needs of our patients in mental health distress. So we will make sure that the way we design these new facilities means that if people attend either of our main hospital sites with mental health needs as well, we will provide the right environment for both their physical and mental health needs to be treated together. So finally, on this section, I've described, albeit at quite high level, how we will need to move services between the two sites. And we know that this will inevitably mean some individuals will have shorter travel times, some may have longer travel times, and we know that finding ways to improve access to services at both our main hospital sites for all users and their families has to be central to our plans. So to assure you, and this is something we can certainly bring forward to you as the proposals develop, we have started and will continue to refine detailed travel impact assessments by specialty, by locality, by whatever measure we can to make sure that overall the impact on our on people accessing services is improved, not diminished. And we will work very closely with colleagues in the local authority to look at how we can support improvements to our public transport and hospital car parking to link those to that when people need access healthcare, they can do it easily and equitably as possible. So I'm going to hand over to Alex to talk about how we plan to continue to listen to the public as we develop these proposals.
So thank you, Lucy. If we could just click on to the next slide, please. So we're currently live. So that went live just towards the beginning of this month, and all members were sent a copy of our engagement document and survey on the 7th of March. So that's been the main way that we've been making sure we've got a really clear summary for the public of our proposals, which Lucy's taken you through. This listening exercise runs through to Friday this week, but it's important to recall that this is about continuing the conversation that we started back in November 2020 and is part of our ongoing listening conversation, which will inevitably include a full formal public consultation probably later on this year. So there's both been a number of historical opportunities for citizens to feed in and will be further opportunities. We are still at quite a formative stage of this process. So we've been promoting this opportunity for citizens to feed in through all the ways you'd usually expect, through placing materials through our key local media, through East Midlands Today, through sharing on our social media, through working with our other health and care partners to make sure this is put in front of as many people as possible. We've run a couple of public meetings already, and there's one more this Friday. And then critically, we're also doing a lot of work with lots of other interest groups, community groups, because those real sort of specialist interest groups or particular community groups are a really rich source of intelligence for us. So we'll be drawing all of that together and analysing it and thinking about what that might mean for how we might adjust or improve or refine the proposals. And then the stage after that is to consider, do we need to do more detailed engagement or discussion of some of the proposals, or are we ready to move on to a formal public consultation? Either way, there will be a formal public consultation, so a further opportunity for people to feed in before any firm decisions are made. I think Lucy's just going to take us through the sort of timetable of what that might look like.
Sorry, and in the interest of time, I'll just be very brief. So, we are designing for the future, and this is a long-term programme with completion expected by the end of the decade. We don't want to rush at this. We will not rush at this. You get a once in a career, once in a generation, once in a lifetime opportunity to do something like this and hopefully fix the best and most, up-to-date facilities that we possibly can. You don't want to rush at it, but equally, I feel we've got an obligation to get on with this at reasonable pace so that we can keep ahead of and at the front of improvements in excellence in service and facilities for our population. So the target date is to have the new facilities opening in 2030, but it's this sits at the centre of, you've had a previous presentation around another reconfiguration. This sits at the centre of a whole system reconfiguration strategy. We want to take our time now to listen to you. We want to listen to the experts. We will be driven by the best clinical evidence, but we want to hear what works for our communities. And this is part of doing that. So we'd very much welcome any feedback from you today.
Thank you very much, Chair, and thank you for the presentation information. Yeah, just a few things, really. The current respiratory facility at City Hospital, which I think part of it was provided by Wolfson, I think through the cystic fibrosis. That's correct, isn't it? It's a specialist centre at City Hospital, which was paid for by a charity, as I understand it. Somebody very close to me went through a very difficult time, early COVID, we believe it was very early. It was believed that it was a serious lung infection. We were told immediately to go to the hospital and was then transferred to the cystic fibrosis unit, and it received incredible care there, I must say. I'm just wondering, because this as a unit has been funded by a charity as opposed to by the NHS, how do we transfer that ownership in terms of the funding and all the rest of it? How does that happen? Because would we build a replica unit under the new scheme at QMC, and that funding from that previous unit would then be however you would do that in a transfer of service cost-wise, would that money that had gone in still then be reused in the new facility, or is that just gone, flattened, and all that sort of charity time and money is gone? Another thing around the geographic, you've mentioned the travel time thing, and that is quite a big concern. I mean, I think geographically the usefulness of the City Hospital for its provision is that it's located, sort of between the QMC and Kings Mill, and so you do get a good sort of spread of access there. And moving it all to the QMC unit, which is quite unfriendly for parking, I would say, as a default, and unless you get a tram or you're on public transport, very difficult to drive and park. Luckily, I was good friends with the vicar who used to let me park in his car park, but if it wasn't for that, I would have really struggled. So I'm interested to know what your provision is. And I know maybe I'm jumping the gun quite a lot here because I realise we're just in the early discussions, but I suppose what I'm saying, we need a really good plan for parking, a really good plan. It can't be you know, we don't facilitate that on site. We've got to be going underground. We've got to be, you know, whatever it needs to be. There's got to be a good facility for parking for patients, absolutely, to enable that. Specifically, if we're relocating the hospital from what I would say is quite a local location to a lot of people to what will be quite a remote location for a lot of people. I also wondered if there's been any discussions, because you're existing on the A60 route, which obviously connects both hospitals, whether there's been any discussions about some sort of public transport provision as well, whether that's through a tram, or if there's been any discussions around that to connect all those things up together. What was the other thing I was going to ask? That was on geography, transport, logistics. Yeah, and I suppose finally, I mean, something that this is something that's become obvious living in a village, strangely, that with what's happened with COVID, very early on, it was spreading around sort of the suburb areas where the areas are interconnected. It was spreading very quickly, and sort of you would see jumps because the areas had no obvious boundary, and you would see these entire areas suddenly get the COVID figures, and you watched, as we were getting the constant updates, you could see it spreading. And the villages, because they had their own co-op, they had their own doctor surgery, their own dentist, that spread didn't actually happen in the same way. And in fact, it sort of arrived and then left, and then didn't come back again for a period of months. And what I'm getting to is that within the makeup of the new hospital and the way that the layouts are being thought out, are we, instead of it being all linked up and effectively, as the QMC is, it's all one unit. What was great about the Circle facility was its independence and its ability under one roof to deliver what is a fantastic service. I wonder if we're thinking in those similar terms for the new development, so that when you do get issues of mass outbreaks of disease, that we're not spreading throughout the whole hospital population in one foul swoop. And in fact, because the doctors and nurses that are working within that specific area remain in the actual confines of that area for their day, they start there and end there, that disease control can be massively improved across the whole system, and that you aren't losing that mass of, you know, sort of, if you like, you're not losing that ability to contain it when it kicks off. Thank you.
So I can have a go at these, and I think James may want to comment on some of them. So the CF unit, you're absolutely right. It's a dedicated facility for it's all single rooms, isn't it? And it's certainly been built in the last 15 years. That won't move, it won't change, and actually the pathway you've described will be no different. That if you have somebody with an acute respiratory illness, the issue is at the moment that the ambulance might take them to City, and then they might have to transfer them to Queen's because their acute illness is such that they need a type of test or a diagnostic or an ITU that's only available at the Queen's. And then that patient would come back when they were in that more stable state. So what we're saying is, or the journey you've just described would be no different. They'd be to Queen's, they'd be transferred to City. So we're not, but what they won't do is move between the two. So, you know, when you're really acutely unwell and you really need all that expert help, you go to Queen's. But when so there won't be, we're not going to demolish it any more than we are going to demolish the Maggie's Centre. That's why we're saying, you know, we've got these great facilities at City already, other great facilities. Sorry. Yeah, like urology. We're going to keep them there and we're going to build on them. So I think don't worry about that. But actually, the pathway that you've described is exactly what will continue. So and that's the great thing about the City Hospital. It's got some very old estate, but it's got some great estate, and we want to continue to use that. So I don't know, James, would you anything to add on that particular clinical pathway issue?
No, I was just going to explain what you just said.
Yeah,
it's
yeah.
Still going to be there. It sounds like
Yeah. But you won't there's no risk that if you're so acutely unwell and you come into the City that you have to go to the Queen's to come back, you'd get stabilised and then you'd go. So the travel times, forgive me, your question, I think what you were saying, and do feel free to correct me, is that you are absolutely right. You've got the city that's Queens that sits on the south of the city. You then got the city campus, which is only 12 miles from Kings Mill, and you are absolutely right. We're very mindful of that. The fact that the way we move services round might impact on the way that people access services, which is precisely why we will do this very detailed travel times analysis. So we're not actively at the moment looking at things like extensions to the trams, but we are looking at, for example, do people access care? And I will use this as an example. It's not a real one, but do people from Ravenshead access care at the city campus that actually could be as well or possibly even better provided from Kings Mill? And if that's the case, that's the sort of thing we want to be. I mean, we need people to be able to retain an element of choice, but these, those three main sites, and of course Newark to the east, because it's the same. People, we would be encouraging people who live in the east of the city and the county to consider Newark Hospital. So I think what we have to do is we need to look at them as a network. We need to look at where people are travelling to now and why, and where there is choice, we need to help people to exercise that choice. Because you make a very good point. If you had to have a routine scan, and I lived in Colic, it might be much easier to go to Newark, get parked, have my scan, come home, than go into Queens. So those sorts of things, I can't give you the detail, but just to be assured that we are looking at all of these sites as a network. And although having said that, we have to be really clear that there are some very specialist services that will only be able to be provided from certain sites. We can't provide everything everywhere. So does that kind of I think what we will be able to bring to you as we get through this is what our travel times is telling us. Analysis, we can analyse data at very, very at postcode level actually, and at condition level. And
I think what I'm trying to, I suppose what I'm trying to say, I don't want us to get us caught in a pigeonhole where we've decided that this is going to happen there.
No.
And then when you do your travel reports and all that information, and you've got that data, that we're so down one road that we can't pull ourselves back again. So I suppose getting all the data in.
No, absolutely. And what I would say, and I think your point about infection control that James might want to add from a clinical perspective, one thing I would say is one of the things that we have to do with this money is anything we refurbish or build new, we have to have an aim of having 70% single rooms. So that in itself will make a massive difference to control of infection, to privacy and dignity, actually to how we can use facilities, because you can manage sort of male and female. So the aim, whether that is certainly one of those national conditions that we have to aim for 70% single rooms on both sites. I think the other thing that I would say that will help us manage the impact of spread of infection is this is exactly why we want to separate planned care from urgent care. So just today, like many systems, both of our acute hospitals with A&Es, so Kings Mill and Queens, are very, very busy with people being admitted with COVID. COVID spreads, and then what happens is that beds that were allocated for people to have their hip operation can't be used. And what we're saying is that by actually really focusing planned care at the city hospital, we should be able to eliminate that thing that happens. It doesn't just happen in Nottingham, it happens everywhere. So that is our reason for saying, hopefully in 10 years' time, if I'm having my hip done, I'll be having it done at the city, and I will know that whatever the time of year is, that capacity is protected for those planned operations while Queens is doing emergency. So they're sort of general points, but I think the 70% single rooms is a huge, will go a long way to helping manage spread of infection. I don't know, James, do you want to add anything?
Well, I was going to add, first of all, on the parking. I was at Queen's this morning, so I'm fully aware of where the issues are. But it's actually a more complex question. So the easy answer is we need more parking spaces. The more complex answer is, as we learned through COVID, actually we can behave a lot better or deliver better services by doing things differently. So there are a whole group of people who are turning up to outpatients to get the result of a test, which we can do, and we are starting to do digitally. So the actual numbers that go into our travel impact assessment are not the same as the numbers that we're looking at now. So we're trying to predict how things will look in the future so that we can create that emergency estates where people who are actually ill and need to be seen quickly have got somewhere to get in and get to. But we're not clogging up the system with people that don't need to be there. So it is a more complex question. And I would say parking is possibly the first thing that comes up on every scenario that we come up, and not surprisingly. So already I do know that there are discussions happening about what we can do in the very short term to look at that as a precursor to be able to do this, not wait 10 years to solve that problem. Because actually this is what we're describing is an 8-year solution, and actually that needs a solution better than that. So it's sort of out of scope of what we're describing, but it's a very real problem that we're trying to use this as a stepping stone to bridge, if that helps.
Probably just to finish on that, there are 2 schools of thought about car parking. So just to say, there are because these are only proposals at this stage, because this all could change, couldn't it, with public consultation? But there is the scope on the Queen's campus to rebuild, multi-storey type car parks to increase the car parking, to alleviate the concerns that you describe. So there is the scope to do that, but there is another school of thought that says actually we need to provide much better public transport so fewer people need to rely on their cars. So we've got to get that balance right, accepting of course that when you're arriving to give birth you're probably not going to come on public transport, are you? So we've got to get that right, and we've got to get that balance right.
Just to come back again on that, thank you. Yeah, I think the car parking, I don't want us to fall into a trap of believing that public transport will be the answer, because again during the pandemic the public transport was stopped pretty much. Let's be honest, and people weren't using it. My worry is, I'm all for people using more public transport from an environmental perspective, and 100%. I think one thing that really appealed to me and why I always talk about the Circle was its ability for you to, if you've got an appointment, you park underneath. I've never not been able to find a space. You park in, you get up, you do your thing, you get in the car, you leave. And for me, that ease of access removes a massive barrier. If I'm going to the QMC and I'm not going to the Circle, I'll be honest, immediately in my mind I've gone, well, I'm going to park. And it's the first thing that crosses my mind every time I think about it. Not, I've got to get to the hospital at this time to have this appointment. This is really important. It's where I'm going to park. And my ultimate concern with it is that it does provide a barrier to some people sometimes. And I think that, and if we are then, as a result, people are thinking, well, you can get on the tram, but, and I wish and hope a lot of people do use it in that way. If they're ill, like you pointed out, they wouldn't want to do that. And the convenience of doing that, nipping out from your job to quickly do something and pop back in, also is difficult within public transport. So yeah, I mean, and car parking, I can completely get why that's such a high priority for the public, because it's a high priority for all of us, and I think that's, if we can get that right and we can resolve that in a good way, and whether it's that you create car parks that people, are for specific departments like that, because I can't say this high enough of how good that place is, because you can get everything done. I remember going in once and having an appointment with a specialist. Within an hour, I'd had a chest X-ray on the same site, and then I think another half an hour after that, I was walking out with a prescription on the way home. That sort of turnaround in time is incredible. The stories that I always hear about emergency care, it's 4 hours default. Everyone always says it's a minimum 4 hours. And so to have that in sort of unplanned, i.e. the chest X-ray was unplanned until I'd had that meeting, to have that unplanned and delivered that quickly was fantastic. But being able to get to it so quickly, do what I needed to do and get out, is what I think high percentage of the population want. They don't want to be in hospitals for very long, because of the chance of picking up something else, of another disease or whatever it may be. So I think the quicker we can get people in and out, the better. Thank you.
Thank you. I think I can assure you I mentioned that yesterday as well in the brief. Oh, yes, because my comment to James and Alex was you can plan everything in the world, but if you haven't got the infrastructure and the car parking, you can't get there, people won't use it. Councillor Welsh, you're waiting, sorry.
Yeah, I'll be as quickly as possible because time's obviously ticking on. I'm assuming that the part one, stage one, the hypothesis of all of this change is to get the best possible care for people in Nottinghamshire. None of us would disagree with that. My concern is where we are at the moment with regards to delivering that care, and where this transformation figures ensuring that people still get the care, and people are working on this, and this project, because it's an amazing amount of work, I don't necessarily disagree with the ins, and I would need to know more information to make a complete valid, but some of that is unknown, isn't it? You don't know necessarily how this is going to play out in the end, but it's that level of care that I'm really interested in. For example, I had a bit of a different experience in NUH 2 weeks ago, where I had to go to A&E, and it was 16 hours before I saw a doctor, a consultant doctor, and when I did see a doctor, they needed to get me up to a ward as soon as possible, and they thought they were going to have to perform emergency surgery. Luckily, they didn't. But when I walked through the door on the screen, it said 14 and a half hours wait. And on top of that, there is nowhere to get any food or drink within that emergency department unless you go up to the main entrance. So people of all different ages, including elderly people, were going up to reception and saying, I've been here now for 7 hours, I need something to eat and drink. Where do I go? You go up to main reception, but this is what the receptionist said, but if your name is read out while you're not here, you will go back down the order. So there were 70-year-olds, elderly people. I was actually doubled over in pain and ended up having to be on morphine when I eventually saw a doctor. Now, if you're going to tell me that the care for people in the emergency department would substantially change and be so much better because of this work that we were doing, I think the whole of this committee would be like, yes, let's do it, we're totally on board. But I would need a bit of convincing on that, because certainly what I saw, when I went up to the ward, it was like being in a different hospital. Got bed ready, water, everything was absolutely wonderful, talking to me like I was an actual person. So that's fundamentally what it is. If people are going to get the care and care is going to improve, that should be the main focus with regards to this. And I'll go back to a bit about the Women in Children's Hospital. A Women in Children's Hospital, in my mind, is absolute phenomenal idea. You know, something that is there for women and children to access. Here's my 2 concerns. One concern is about choice. I think that women's choices with regards to health is limited anyway, across all health services on where they should have their baby. There is a culture in Nottingham as well that exists about, if you live in certain areas, you go to the city hospital, and if you live in other areas, you go to the QMC. And, you know, amongst women in women's groups, there is often a favouring towards going to the city hospital because it is seen as a smaller, more, I'm not saying that that's the case, but it is seen as that smaller, holistic approach. And I think there's some real work that you will need to do with regards to working with women, just in general, over different ethnicities, social, economic groups, women with children with special needs, for example, as a focus group as to how that Women in Children's Hospital actually develop and plays out. Because, as I said, there's this cultural thing, but there's also a bit of understanding about how women access health. And I'll go on again, as just one example, you talked about having all of this together, including the fertility department. If you've been on that fertility journey, going into a hospital where you are seeing lots of women walking out with babies is very, very tough. Especially if you're walking out knowing that it hasn't worked and that's your last free chance on the NHS. So this is what I mean about talking to women with regards to what their experiences were previously and how that'll work with regards to the development of that hospital. And I would be really keen to hear what other women feel about you will have your baby at the QMC. You know, that because yeah, home birth as well, of course, but predominantly you're going to have your baby at the QMC, and the city hospital isn't going to be a choice anymore. And I think how you communicate this, I don't think you should underestimate how massive it is for women in Nottingham, especially in Gedling, where I'm from, because literally it's a thing where women in Gedling have their babies at City Hospital. You know, that's what happens. And the QMC is actually sitting a lot further away and a lot bigger and a lot more left. And my last but not least, and I won't dwell on it too often because I did talk about it extensively when we talked about maternity services. I'm worried about maternity services, as I've made quite clear. I understand this is more than rearranging the deck chairs with regards to what happens, but I would like some further information with regards to how this will actually help maternity services improve. So I understand you're going to have all of that staff on one site. That'll only work if you have the right amount of staff, that the cultural situation happens in the maternity department, and there are massive improvements in the maternity department. It's a bit like a school. You can have a really old building and it can get outstanding at Ofsted, and you can have a new building school with everything that can fail Ofsted. It's about what happens inside, isn't it? Inside those buildings, not necessarily a rearranging where everything is. And last but not least, and then I will shut up, promise. Councillor Adams brought up the element with regards to transport. When you, Councillor Turner, mentioned it as well previously with regards to having a women and children's hospital, I find more and more when you go to these places, there aren't women and children's parking spaces. So when my boy was not very well during the pandemic, it wasn't an option for me to go on public transport because he was vulnerable, clinically vulnerable. So actually I drove. And I can remember being refused to go refused a space in the Circle Centre, even though there was a few there, because I wasn't going to the Circle Centre for treatment. And driving around and around QMC, ended up quite emotional about it because I was going to miss him, despite being 45 minutes prior to my appointment. So if we're going to have a women and children's hospital, the transport plan is really fundamental because it's who's going when, how and what. Because the other reality of it, a lot of parents that have children work, so they don't have the full day to park at the forest, get the tram and go up. We have to make it work for women. And I think this is really where a focus group does come in, and we try and reach out to people across Nottinghamshire with regards to how that women and children's hospital will look like for the future, and I'd certainly welcome being part of that if you would want that to happen. But I'd be interested to see how this progresses further. But ultimately, as I said, if this means that care will improve and the situation in accident and emergency will improve and maternity services improve, I wouldn't have a problem with it. But if it means that people feel that health services are harder to access and that doesn't improve, then obviously I would perhaps look at this very differently. We're in the initial stages as far as I'm concerned, so I would need more information. But I do thank you for the level of information that you provided today and what you said, because it's very, very useful for us. I think as we go on, we just need a bit more further information.
So can I just probably slightly apologise, because in the interests of brevity, I didn't. So when we talk about the family care centre, and just out of interest, we have it, one of our bits of feedback is that to make it accessible to all people, however they identify and whatever their gender is, we should actually ditch the women's bit and talk about a family care centre. But that in itself is a matter for, those are the sorts of things that we are really happy to talk to you about, because if calling it women's and children's is difficult, makes it difficult for people to access, that's one perspective. Another perspective is that women have, and I am a woman clearly, have very specific needs. So those sorts of things we can talk about. First thing I was going to say was we would definitely anticipate that facility will have all the paediatrics, and I just would urge us to remember that it's not that long ago we had paediatrics on 2 sites. We moved them all to the Queen's to create that centre of excellence, and it's worked. At the time I worked at the City Hospital, I thought it was terrible, but actually it's been great to get everything together. we'll certainly have one birthing unit. We believe the clinical evidence is that that's the best way to build and retain the right workforce. I came, I think, to talk to you about neonatology, and we believe that that is the best way to build and retain the right workforce. But you are right, fertility, genetics is the other service that can be people going through a process that doesn't necessarily result in a good news story, and potentially gynecology. They are services that we traditionally associate with women and children, but that we are willing to hear from the public whether we think that actually putting those in this centre is the right thing to do or not. So to assure you that they're very live topics that we are thinking about. So the only other thing I was going to probably say to you around the your question about, are we hanging our hat on this thing that's going to happen in 2030, solving all our problems? What I would say is, we know the City Hospital was built in Victorian times. It's been extended, added, reconfigured. The Queen's was built in 1979. I think it first opened. Again, it's been extended, reconfigured. This is an opportunity to kind of logistically get this as good as it possibly can be, but we do have to get it right. And we also do recognise that we will probably be coming back to you. If we can settle on where we think 2030 needs to be, which is what this process is about, I anticipate that I will be coming back to you on a very regular basis to say, actually, we don't need to wait now until 2030 to do this bit. We think we can move this service that's at Queen's that would be going to the city in the end anyway now, and start to make those changes now. So we won't, that will be a process that we will go through. But what this is about is settling on the vision for 2030. I'm sure that James can give you much more flavour around the realities of urgent care at the moment. I'm just going to say that, as we know, our urgent care services have and continue to be under massive pressure. But I'm going to hand over to James to perhaps address that question in particular.
Well, I mean, what I've just written down, really, for me, the building work's an enabler. So challenges of clinical care, culture, all of that stuff are all things that need addressing, independent of whether we build a new building or not. This is about making sure that the buildings aren't something that hold us back, so that in the future we've got the best chance to deliver the best things in the best place to the most amount of people. So I was going to say again, with parking, you talk about dedicated for women and children's, what we need is the best for all the groups of people that go there. And that's where the travel impact assessment is going to be key, because I think it's going to be really complicated, because I think we need to take every group and ask what's going to change. So if we're moving respiratory to sick Queens, what's the impact of that? Is that more people? Is it less people? And this isn't easy. So I think this is going to be a long thing, and the more people that can give us focus group thoughts, the better. We just need to understand what people need and want. I was going to bring up the gynecology issue, because we're still debating about whether it's right for them to be in, or if it's right to be in with a different entrance, a separated area. So all the expertise is there, but you've got different phase. It's not decided, but it is a real discussion that's happening. And I was just going to acknowledge your point about women's choice, because I think, I'm a GP in Calverton. Nobody in my place wants to drive past the City Hospital to go to Queen's. It's just fact. So we've got a piece of work to do if we're going to sell this as a positive thing. But this is a plan for 8 years' time, so we have the time to do that. And I think we need to build this. Well, we need to work out what we think is right between us, get the consultation right, reflect on it, and then we've got partly a sales job where we actually make sure people understand why we've got to where we've got to and what the outcomes are going to look like. So this isn't a point in time. This is a journey, and I strongly think that we need to remember this is about making our buildings as good as they can be, which is separate to some of the challenges, which we need to look at independently and quicker, or more quickly.
I'm probably sorry, Chef. I could just summarise. We have described something that feels like it's going to be bigger, and actually it shouldn't be. Overall, it should be smaller. Things will move between the two sites. Most of our emergency care at Queen's, a lot more planned care at the city, but actually the footprint should be smaller. And we have a duty, I think, City Hospital, I am particularly fond of that as an institution, but the bottom line is we've got Nightingale wards that were built, prior to the First World War, and we've got a duty to, if we can access capital to replace those facilities, to create more modern facilities, we need to do it. We need to do it right. But I think what we should fix in our mind is a really good result for all of us is if the new hospital sites, as well as being more modern, is they're actually physically smaller and less people, as James described, having to visit them. So thank you very much for your time.
Can I just the last one on my list that I picked up on that I didn't answer. So the emergency care bits. So ED is a problem. So as a system, I'm the urgent emergency care lead. So although I'm not responsible for Queen's, I'm trying to be responsible to help the strategy and look how we can go for the future. And what's really clear as you scrape under the surface is there's lots of stuff happening that isn't as good as it could be. So there's lots of problems with general practice access. So people are turning up in ED when they could be in general practice. There are urgent care needs that could be delivered in better places. So part of designing the NUH pattern is about trying to make it fit with the strategies we're putting with it. So the community services strategy and all the other strategies that we've got wrapped around it, so that we can deliver the right care in the right place. So again, going back to what Lucy just said, this isn't about trying to make ED bigger, meaning we need more staff and meaning we need a bigger place to try and accommodate what's happening there. It's about stepping back and saying, what can we do better as a whole? Too many people are travelling too far to go and get care they don't need in a building in the Queen's, and somehow we need to unpick that and what we can do to make it easy. And that's a really challenging thing. What I said, I made it sound easy. Actually, changing how as a GP, on a Monday morning when people say you can't get in, it's tricky. It's tricky, but there's a whole. We've got to get to a place where we can start to accommodate that urgent need that is out there, amongst all the other things that require doing.
Thank you for that. I've got a question to ask, but I don't want to hold the meeting up anymore, but believe me, I shall ask it next time. And just so you can be thinking about it, so you'll have your answer when you come back. Supposing there was, you've got your elective surgery one side, your emergency surgery the other side, and there's a massive train crash, let's say. Will you have enough experts in the emergency department to deal with that accident without when the others are over at City? That'll be my question for you next time. So, at 2 o'clock, I think I've certainly got another meeting, and I know Bethan has. So, I want to draw it to a close. Now, I would like to thank you very much, and I would like to offer you my apologies because we are running late. And I've written a note to Martin that these agendas were going to have to get smaller, but it isn't easy because when you've got proactive members, there's a lot of questions to be asked, and we have to make sure they're asked. Lucy, James, Alex, when do you think you should come back again?
Because you can see we're very enthusiastic about this. It is genuinely the biggest thing any of us are going to ever do. So we will come back as regularly and as thoroughly as you want us to. But genuinely, I think a good time would be, I think we've sort of said maybe July time, when we've evaluated the feedback from this open public engagement we're doing now, account of all the sort of, and we can come back and say this is what it's told us, because we've got some themes already, and particularly around some of the issues that Councillor Welsh mentioned. So I think possibly we thought maybe July we could come back and say this is what the public are saying to us. How do how do we work together to take it forward? That would be the next
make sure
iteration.
you are higher up the agenda.
Yeah, I mean,
because we have maternity coming back that day, I think, so we'll put them to the
right.
bottom.
Yes, fair do. Yes, okay, we'll do it however you wish us to do it.
Martin will be in touch.
Yeah.
And members, before you all go, we're just altering the next meeting a little on 10th of May, in so much as we need to include primary care strategy. So anything else has to be moved a little bit because that is important. Okay, thank you very much, members, and thank you to James, to